Okay. Good afternoon, everybody. Welcome to today's meeting of the IJB in Perth, Kinross. Can I just remind members that the meeting is being broadcast? Have I got? Sorry, bear with me a second.
Is your microphone on your lap?
Should be fine now. I'm Brian Jones, Chair of the Integration Joint Board. Welcome to today's meeting. Can I first of all congratulate Zoe on the appointment as Chief Officer of the IJB? Can I also welcome Chris Bryce as new member, as Non-Exec Director of NHS Tayside? Can I also take the opportunity to recognise the resignation of Nettie Patterson from her role as service user public partner representative, and to thank her for all of her contributions to the IJB. Can I introduce Colin Stewart as Vice Chair, Donna Mitchell, Chief Finance Officer, Jess Guild, Clerk to the Board, and Scott Hendry, Democratic Services Manager. Clerk, can you confirm any apologies received?
Thank you, Chair. We have apologies today from Keith Russell with Sarah Kettle substituting. We have a few members who aren't present yet. If they do join, I will let you know. Heidi Douglas, Monica Doyle, Bernie Campbell and Roisin Smith.
Thank you. Can I remind those joining us virtually to use a chat box to attract my attention? Can I ask if there are any declarations of interest in respect to the business on today's agenda?
I'm the alcohol and drug champion for NHS Tayside, and there is a report.
Thank you, Martin. Can we move to the minutes of the previous meeting of the Joint Board on the 18th of March? Can we agree the minutes? Yep. Anyone second? Yep. Thank you. Any matters arising from the minutes? I think there are. No. Okay. Thank you. We are changing the agenda slightly today to accommodate other individuals that need to attend other IJBs in Tayside. So moving straight on to point 5, and we'll take the primary care foundational strategy from Jill Robertson first. Zoe, you're going to introduce this.
Okay, so Jill Galloway, Chief Officer from Angus Health and Social Care Partnerships, going to talk to the primary care foundational strategy, which sets out a whole system collaborative approach to stabilising and strengthening primary care across Tayside. The strategy encompasses general practice and contracted primary care services alongside multidisciplinary team models, improved urgent and out of hours and care pathways within community settings, and is aligned to emerging national policy, including primary and community care route map and the Scottish Government's Health and Social Care Service renewal framework. Pass over to you, Jill.
Thank you, Zoe, and thank you, Chair, for accommodating a shift in the agenda. So thank you for asking me to come along to present the foundational strategy for primary care 26 to 28. This has been developed in response to an NHS Tayside corporate objective from 25-26, aimed to establish a clear shared strategic direction for primary care across Tayside. The strategy has been developed collaboratively with representation from all 3 health and social care partnerships, NHS Tayside colleagues and all 4 independent contractor groups, as well as our public partners. That's to ensure that it reflects both local priorities, wider system requirements and any national direction of travel. The strategy was endorsed by NHS Tayside Board in April 2026 and has also been supported by all 4 advisory groups in relation to all of the independent contracted groups and NHS Tayside's Area Clinical Forum. Members will be aware that primary care delivers approximately 90% of NHS contacts and is really fundamental to prevention, continuity of care, population health improvement, and the longer-term sustainability of the wider health and social care system. The strategy recognises that primary care is significantly broader than general practice alone and encompasses the range of primary care services, including general medical services, community pharmacy, community optometry, and general dental services. Members will also be aware that in December 2025, the strategic vision and plan for out of hours service was also presented and supported and approved. This is part of the corporate objective also. Together, they are critical interfaces with urgent, planned and community-based care mean that it is extremely important that we have a strong foundation to build and develop wider primary care services. And this strategy provides for the first time a single strategic framework for the whole of primary care contracted services across Tayside. As lead partner for primary care services across Tayside, Angus Health and Social Care Partnership and IGB has coordinated the development of this strategy on behalf of all three integration joint boards and NHS Tayside. The strategic coordination role extends beyond general practice and includes supporting the development of a coherent, sustainable and clinically led approach across all four independent contractor groups. The strategy does not alter existing operational responsibilities and it is recognised that the operational management and delivery of primary care general practice services remain the responsibility of individual health and social care partnerships within their areas. The strategy itself has been intentionally designed as a 2-year foundational strategy rather than a longer-term transformational strategy. This reflects the significant national policy developments currently underway, including the anticipated Scottish Government Primary and Community Care Route Map, which was due for publication in June and has now been deferred until autumn 26, alongside other emerging directions for primary care, including excellence in pharmaceutical care and other optometry and dental services. The strategy therefore provides a practical and realistic bridge between current position and longer-term transformation of primary and community care, focusing initially on stabilisation, sustainability and strengthening the foundations upon which future reform can be built. It aligns closely with the National Health and Social Care Reform Principles, which Zoe has also already alluded to, and supports the wider shift towards prevention, proactive care, multidisciplinary team working and other community-based models of care, as well as reducing health inequalities. It recognises the critical role of primary care in supporting whole system sustainability, improving population health outcomes and enabling more care to be delivered closer to home. Importantly, the strategic priorities set out within the strategy are consistent with and support the ambitions of all three integration joint board strategic plans. The focus on prevention, proactive care and integrated multidisciplinary working, care closer to home, workforce sustainability and population health improvement is reflected across all three integration joint boards. Therefore, the strategy provides a common framework whilst allowing for local delivery plans to be developed and implemented in a way that reflects local needs, circumstances and priorities. The development of the strategy has been informed through extensive engagement with stakeholders from across Tayside, as I've said, all independent contractors, advisory groups and NHS Tayside. The next phase is to co-produce the associated delivery plans across those independent contractor services. This approach will ensure that implementation will continue to be shaped collaboratively and that local expertise, experience and priorities remain central to the delivery. Approval of the Tayside Primary Care Foundational Strategy today will provide a shared direction for primary care services across Tayside, support greater alignment across the system, strengthen collaborative working across all primary care contractor groups and establish the foundations required to develop a longer-term primary care strategy from 28 onwards. The report in front of you, Chair, has some recommendations, but just before I pass on to any questions, just invite Zoe, and I'm not sure if Hamish or Sal are in the room, but they've both been involved, Sal particularly, who may want to add anything to the conversation and provide assurances from a Perth and Kinross perspective around engagement. Thanks, Chair.
Thank you, Jill. Sal, would you like to add anything else?
Certainly from a collaboration point of view, I've actually been involved in several meetings around this in several different forums, whether this is being related to the LMC, whether it's been related to, and I'm going to say XLT, but I might be wrong because I remember you presenting it there. And also we've been involved with the sort of working group that's actually developed this. And I think there has been an extensive amount of engagement within the limitations of the fact that this is only a 2-year. The bits that that are really highlighted for me, which I'd like to be recognised, is very much about the complexity of primary care, which makes it very different from other strategies. The fact we're working with different models, whether it's people employed with NHS Tayside through to the difference between 2C practice, but very much I think the independent contractor role and model that's there. One of the things that I was really pleased to read in this, and one of the things is this idea of stability and sustainability. I think we've seen a lot of change recently in that area, and I think having that period to make sure that our services are stable and sustainable is really vitally important. And there is lots of things nationally that are going on. The other thing that it highlights, which is obviously fundamental, is MDT working, which I think we've made fantastic developments forward in this. But we just need to refine that process and make sure it's value for money and effective for our patients. And just the final thing is just that I think we need to recognise that we're awaiting the national route map. And although the team who've developed this have done lots of things to get in the national perspectives, whether that's optometry or pharmacy, we're still waiting for that route map, and we've been waiting for quite a while for that. So it's been very difficult to develop anything too far ahead because we really need to see what that shows us.
Thank you. Does the board have any questions on this paper? Lindsay?
Thank you, Jill, and thank you for the paper. Obviously, looking through it, there is a lot about engagement, which I'm happy to see. I'm just conscious of things that have been happening in the not too distant future, and just a wee plea that staff side for NHS staff that are around your multidisciplinary teams and within primary care have representation from partnership colleagues around that, and it'll also help with the staff governance standards so that you can evidence that you're doing that as well. So obviously I know I'm part of some of these groups that are listed within the papers, which is grand, but I'm conscious that we do have other unions and other professional bodies that sit around the APF table, such as your optometrists and things like that, that may want to be involved in that. So if you could keep me posted, and I can liaise with my colleagues to get the people around the table that you're needing for this to move forward, because I agree that there has been a lot of change in primary care, and this has at least given us some route and a strategy to work to, and I understand for all the change. So I'm not saying I'm not happy with it, I'm saying I am, but it's just if we can make sure that staff side are around the table. Thank you.
Of course, happy to come back on that, Lindsay, and confirm that staff side and other advisors from the other independent contractors are and have been involved in this. And obviously from an Angus perspective, our staff side rep will take a lead in anything relating to that and link in with other staff side colleagues. So provide the board with that level of assurance. Thanks, Lindsay.
Thanks, Jill. Councillor Stewart?
Thanks, and thanks for the report, Gillian, and thanks for the opportunity to discuss it a wee bit last week, I think it was. Everything's a blur now. My question was around the aspect of the strategy which requires the delivery plans, and it was just to know what the approval route for the delivery plans is. If, as an IJB, we're required to scrutinise and oversee the operation of the operational delivery of this strategy, do we also get to see and approve the content of the delivery plans? Because otherwise we could be overseeing something whose metrics and deliverables are things that we don't agree with.
Yeah, of course. So I guess in terms of the delivery plans, I think each of the 4 independent contractors will have their own delivery plans in line with their national direction and their element of this local strategy. There will be a Once for Tayside delivery plan, which will cover all 3 areas. In terms of the delivery plans for the other independent contractors, Colin, there is no operational responsibility for the IGBs around dental, optometry or community pharmacy. So there isn't a specific requirement. However, if the IGB wishes, they would be able to have sight, and that would be brought through any general primary care updates brought to the IGB from Zoe, Hamish, Sal, etc. In relation to the wide, I think you already receive a report around primary care. So given the alignment, I would like to think that any updates and progress could be included in that update specific to Perth and Kinross. I don't see any specific plan being developed that differs from what you already have in place or the direction of travel that you're already moving towards from a general practice perspective. The responsibility of NHS Tayside Board around the other 3 independent contractors is different, so the governance routes do remain different. Overall monitoring will be done through the Primary Care Board and will be provided to NHS Tayside Executive team, and any updates to NHS Tayside Board as required, and each individual IGB may wish to make their own individual arrangements with their local teams.
Thanks, Jill. Councillor Illingworth.
There you go. Thank you. It's a complex environment we're sort of working in. How will we know if the strategy is working?
So included in the strategy and the plan on the page, you will see how we will know we have made a difference. So they will be progressed as part of the metrics to support how we are both progressing and delivering, but the impact that we're having on the population as well. So there will be some hard quantitative metrics that we will consider. We will also take into account qualitative information, and we've recently just had the Health and Care Experience Survey, which will be due to run again in a couple of years. So we would be looking to use that as well. We are keen to demonstrate impact and not just around core quantitative data. So we're also working with our Director of Public Health, Katie Gary, to look at what metrics we can look at from an impact on the population perspective.
Thank you. Councillor Frampton, please.
Thank you, and thank you for the report. Can I ask, will it, out of our strategic framework that is currently being finalised, be brought to us? We don't know what form this will take, but we're asked to approve this report without sight of it.
So this is separate to the out of hours framework. So Perth and Kinross Integration Joint Board approved the out of hours strategic framework in December 2025.
Thank you. Heather? Oh, sorry. Sal, did you want to come back on that?
Yeah, no, I just want to come back on what a little bit about Colin, just for some reassurance to the board. You might know that we've got our strategic development plan. Is it for primary care, which admittedly is very much general practice based, actually comes to an end this year. So we will be producing our final report, and the team have already started having discussions about how we incorporate this strategy into how we present things going forward.
Thank you. Heather?
Thanks very much, Jill, and others who've contributed to this strategy. I enjoyed reading it, and I think it's ambitious, but we understand where the challenges are. I suppose reading it, I would reflect and say probably one of the critical success factors is going to be the data and digital aspect and how that's integrated. And I just wondered, is there a separate digital plan that runs alongside this that will enable all partners to actually talk to each other digitally and hopefully reduce the burden on our staff as well as we move forward? Because I think in order to be successful, we need to be open and honest here about the challenges that we have in the digital side. So I was just interested if there is a data and digital plan underpinning this to make it a success. Thanks.
Yeah, thanks, Heather. A really interesting and key question. So there isn't a specific data and digital plan that will sit underneath primary care specifically. There's a lot of work going on both at subnational level and at local level in relation to digital work. So you'll be aware around the digital front door work. So we need to make sure that we are tapping into the developments there. There has been progress made locally, and Sal might want to come in terms of access to clinical portal, etc., for our other independent contractors to support that sharing of information across the practitioner groups. I'm not going to deny that it's a really challenging space to be in when you're working between NHS systems and independent contractor systems as well. So I think there is a bit of work to be done around that. We don't underestimate the value and the benefit that digital approaches could take. And as we move forward in that kind of more digital landscape, then it is something that we're going to have to look and consider alongside what the digital infrastructure is going to be required to take forward any development around other platforms to support that. But where we can locally, we're really working hard with our digital colleagues and contractor services to make sure that we can share information across digital platforms as easily as possible, in line with information governance requirements as well.
Thank you. Councillor McCall, please.
Thank you. I have a few comments, stroke questions. Gillian, some of them you may have heard before, so for those of you who maybe are unaware, I've seen this paper already at the Health Board. First of all, I want to actually endorse exactly what Heather has said about data. There is a substantial amount of data being gathered and is available through the Population Health Committee and that group. And based on that, I want to pick up what Councillor Frampton asked about the out-of-hours service. As we know, the uptake and the utilisation of the out-of-hours service in Perth and Kinross is substantially lower than both Dundee and Angus. So I think it's reasonable, Gillian, to perhaps ask what can be done in the short term to address that using the data that we have, because it also has a knock-on impact on A&E, we suspect, but we don't know. So I think that's really important that does come back. The framework is fine. I think everybody agreed that was the right way forward, but things have moved on since last year. So I think that's the first point. The second point is one that I've raised previously, and it's around the two different dental services. So as most people in this committee will know, or this board will know, Perth and Kinross Health and Social Care Partnership has delegated responsibility for public dentistry, but you've also got in this report dentistry as well. So it would be useful perhaps to give us a bit of an update on how these two things work together in tandem. And I have another point to make. Hold on a second. Oh yes, the other one, which again you and I have talked about separately, but for the purpose of this board. As you know, there are long-standing gaps in our GP provision in certain rural areas of Perth and Kinross, particularly Bridge of Erne. And so what I would like to know is what work has been done as part of the primary care strategy to ensure that provision for primary care services such as GP practices and or community-based health centres, as we move more towards community-based, the balance of care more in the community, is being done to ensure that current and future need is incorporated into Local Development Plan 3, which is currently in progress with all of the local authorities across Tayside. That's all for now. Thank you.
Yeah, thanks, Sheila. So happy, and I'll work from the bottom up if that's okay. So the Local Delivery Plans 3, we have had numerous conversations both through Population Health Committee and NHS Tayside Board each time I have brought this update through. We have now made links, and I have had confirmation that Dundee, Angus and P&K do all have representation, and I think I alluded to that within the cover report. So recognising the importance of any future developments to include discussion and collaboration with health and social care around the provision of services. In relation to dental services, so although we only reference public dental service and general dental service in the foundational strategy, the work that we are doing also includes hospital dental service. So we do have a dental hospital in Dundee and other dental services within the acute service. So we had a really positive visit from the Chief Dental Officer just back in April that was hosted in Broxton. And part of that discussion was, whilst we know that there's work to be done, there's been a National Dental Services Review from a general dental services perspective. There is a bit of work that we need to do around what is our overall dental strategy across Tayside, which will incorporate public dental, which Perth and Kinross do have a strategic coordination role around, and hospital dental services. So we do need to work that through a bit in terms of how are we going to collaborate to ensure that when we're looking at dental, we're not just looking at one specific element of dental services. We know that general dental services play a critical part in the provision and access to dental services. Public dental services also play that critical part in terms of specific groups of individuals who do require to go to either Broxton or Springfield for those services, and paediatric dental services. So when we're talking about oral health and public health, population health improvement, dental is a huge part of that. So there is an appetite and there is a desire to look at how we can look at dental services across Tayside. And again, Katie Geary from a population health perspective is really keen to be part of that and support that. So we are in the process of setting up a group across Tayside to look at dental services, not taking away from the fact that Perth and Kinross have that strategic coordination role around public dental service. So that is work in progress at the moment. In relation to out of hours, I would be happy to bring a further update back in relation to the work that's ongoing around out of hours. I did take that update to Dundee IJB this morning because that was a specific ask back in December when we presented the paper. So the paper to Dundee IJB and the paper that is going forward this afternoon to Angus is an assurance paper around the progress being made with the implementation of that strategy. So I would be happy to bring that back, Sheila, to a further either development session or IGB in the future if required, or also happy to pick up a conversation out with.
Chair, thank you, Gillian. That's really helpful. I think it's really important that you know, the out of hours service, and so I mean, by all means work with the chair and the chief officer and group here to agree where's the best place to bring that back to. But I think the board as a whole would probably welcome at some point an update. But I think there's a lot of work to be done in the interim. So thank you for that. That's all really.
Thank you. Martin.
Hi, Joe. It's about the data that's been collected. And is it the correct? I sit in the Population Health Committee and I keep asking this question. Is it the data that we're actually collecting relevant, or does it need to be reviewed every year at least, if not sooner? And because I'm not sure what we're doing with the data. We're great at collecting it, but what do we do with it?
Yeah, 100%, Martin. So I think that is part of the work that Katie and myself are taking forward specifically in relation to that, and that will be part of the kind of co-produced delivery plans as well, because we need to make sure that what we're saying that we're wanting to deliver is going to be measurable, but also is going to demonstrate an impact for the population in a positive way as well. There will be core metrics that we do need to look at in terms of access to GP practice. So Public Health Scotland already published some of that information, and we do use that, and we will use that to look at how we plan services. There will be data around sustainability of general practice services going forward as well. We have, I think, Sally, you can keep me right here, maybe at least 2 years worth of data around GP sustainability. We have looked at developing or taking the learning from that GP sustainability survey. We've translated that into a general dental sustainability survey, and we're just in the process of testing that so that we can look to support how we can have sustainable dental services. So there will be some kind of hard, quick data that we either have access to or can get access to, but in terms of the impact and outcome, that's something that we're really keen to work with Katie around, and I know she's keen to include them in the population health section of the performance report as well, Martin.
Thank you, Jill. Sal, did you have a?
Sorry, I just want to come in about this idea of data and measurement, and I have to say that I've personally really struggled with around this. Not because it's not there or that Jill hasn't done a good job. I just think it's a really complex area for looking at this. And in my head, there's two firm bits. So we have got the overview of how we ensure that the outcomes are better for our population. But we also have to recognise how difficult, and this was recognised in key national documents, such as I think it was Audit Scotland, which might have been last year, the year before, about how difficult it is to collect data in a lot of these areas. And that was a key recommendation about making this easier. But I think we also have to recognise that this is going to cover 3 health and social care partnerships. And every health and social care partnerships is going to be at a different position or have different things within their context. So I don't think we can be reliant just on that overarching data. I think we also need to be considering the data that we collect within our teams, within our services that we control within the Perth and Kinross. So for me, it's more complex than just that overviewing, and we need to think about how we're collecting data for our local services as well to demonstrate an improvement.
Thank you, Sal. Thank you, Jill. If there are no further questions or comments, can we agree the recommendations in the report? Thank you, Jill.
Thank you.
Can I ask Zoe Robertson, Chief Officer, to introduce the Tayside Together Palliative Care Matters for All strategy?
So Dave Berry, Chief Officer for Dundee Health and Social Care Partnerships, going to present on the palliative care strategy today, which sets out a whole system approach to improving the quality, consistency and accessibility of palliative and end-of-life care, ensuring services are person-centred, equitable and delivered in the right place at the right time, and they align with national policy and health and social care service renewal framework. The paper came to the strategic planning group in May, and the membership were supportive of the strategic direction. I gave more full feedback, but we'll give that when we give our strategic planning group verbal update. Sorry, I cut off before I said over to you, Dave.
Thanks, Zoe. Thanks, Chair. Thanks for the opportunity to address the IGB today and introduce this palliative care strategy. So for those who don't know, I'm Dave Berry. I'm the Chief Officer for Dundee Integration Joint Board. And with that, I'm also the lead partner for specialist palliative care for Tayside. And from an NHS Tayside perspective, I'm executive lead for the delivery of the Tayside palliative care strategy, which is why I'm here today. So the strategy itself comes from one of the NHS Tayside's corporate objectives for 25-26 to develop a Tayside-wide palliative care strategy, and that's on the back of the introduction of the national strategy, which was launched in Perth and Kinross actually in September, which is the Palliative Care Matters for All strategy 2025 to 2030. So Zoe's already kind of set out, you know, the sort of shared the sort of aims and vision around the strategy. The strategy is designed to kind of respond to those kind of population challenges that we have. So whether it's around the ageing population, and I appreciate Perth has a significant challenge around an increasingly older person's population. The complexity, so more people are living longer with multiple long-term conditions, including frailty and dementia. Sadly, we've got a rising need in children and young people. So within the Tayside area, around 450 to 500 local children are living with life-limiting conditions. And then there's the inequalities challenge that presents, where people in the most deprived areas experience significantly poorer health, but also lower life expectancy. So the national strategy kind of takes into account all those particular issues, and we've pulled that into what does that mean for Tayside. So within that, we've kind of identified that there's a number of kind of challenges that we experience across our services, that we're looking to address. So that includes latent identification of palliative care needs, the workforce pressures, the variation in access across the region, the limited understanding of what future care planning is, the inequalities for vulnerable groups, and then also that limited 24/7 community service availability across our area. So the aims of the national strategy are to enable people in communities and also to strengthen palliative care, based around 8 particular outcomes, which are all kind of set out within the strategy itself. And within the strategy, you'll see that we've kind of, for each of those outcomes, we've set out what it is we've already got in place within Tayside across our services, and what is it we're looking to do to kind of meet the objectives of the outcomes that are set out within the national strategy. The strategy itself has been developed on a kind of a completely whole system approach. So we have a Tayside palliative care steering group, which we set up over the course of last year to develop the strategy. And that group is also connected in with the palliative and end-of-life care managed care network. And the steering group itself consists of representatives from each of the health and social care partnerships, the acute sector across adults and children's services, specialist services, charities, hospices and care homes, given the amount of palliative care that's provided across the whole spectrum of services within the Tayside area. This strategy is being taken to each of the IGBs all today. So like Jill, I've got kind of 3 IGBs in one day today, and NHS boards tomorrow. It's also been to the Population Health Committee of NHS Tayside, where it was supported. Following approval from each of the partner bodies, we are developing a public-facing or a more public-facing version of the strategy to be shared with the public. And that'll be issued once everybody's approved the strategy. And one of the key things is around the actual delivery plan itself. So the strategy is the high level direction of travel. The delivery plan is key around what does it actually mean for services and the shape of services. So we're working through that, and we've got a kind of timescale we're working to of August 2026 for that. So I'll leave it there and I'll see if any questions.
Thank you, Dave. Did the board have any questions? Lindsay?
Hi Dave, sorry, I don't mean to sound like a stuck record here, okay? But as again, I was a part of the Population Health Committee and I have seen this paper before, but I just want to make sure that when we're going through this strategy, which needs to happen again, happy with the paper, but that staff governance is at the height when you're dealing with your staff around these areas, and that you use your local staff side reps, which you already know who they are, Dave. I'm not going to go into that. But yeah, if you could just liaise with myself from here, just so I know that we've got the right people around the room, that would be great. Thanks.
Yeah, happy to do that, Lindsay. And I mean, as I said, the key next steps around the delivery plan, because that'll kind of set out more clearly the how it's going to be delivered, and ultimately that'll look at a target operating model, of which of course staff side will be fully involved in that.
Thank you, Dave. Any other questions on this paper? No, in which case can we agree to the recommendations? Thank you. Thank you, Dave. We'll be returning to the agenda and taking the Tayside Mental Health and Learning Disability Services strategic update shortly, but just to advise the board, we have an additional item at 5.6, which will be a strategic planning group verbal update by the Chief Officer. So that's been put in at 5.6. So next, can I invite Jane Menzies, Head of Integrated Health and Care, to provide the verbal update.
Thank you. So I'm just providing a strategic update with regards to individuals with mental health and learning disabilities. And as you know, the substantial redesign programs that are taking place across Tayside. Overarchingly, I can say that progress is very positive. However, we are aiming to achieve considerable system redesign and positive and sustainable change. So we're very clear that there is much work to be done. As our previous chief officer has updated at an earlier IJB, our work with Step Care Solutions has now been completed. And essentially what that's done is provided us across Tayside with a framework for change. So this means that regardless of where you live in Tayside, the principles of the care and support that you will achieve will be equitable. That does not mean that we can't have local redesign, and that will absolutely be our aim. So what the framework in very brief summary outlines is our ability to establish a single point of access specifically for mental health services, to ensure that services are more embedded within communities and that routes from one service to another, particularly if someone needs a higher or lower tier service, they can move more easily. We're also seeking to achieve earlier interventions for clinical care. So that now that we have these principles in place, the aim will be, of course, to translate these into a P&K response. And that will mean that we require broad consultation, particularly with our colleagues within primary care, but of course, across all stakeholder groups, including carers and those with lived experience. And following this, our aim will be to, although there has been much discussion of the model of care, is to ensure it comes to the IJB for formal sign-off before it's progressed any further, and to provide an overview of the process for taking that forward specifically for the population of P&K. We now have, of course, Dr. Lynn Taylor, who is a welcome addition to the programme, who's now settled in as the exec director for mental health within Tayside, but crucially has a system-wide oversight in terms of making sure that we can take opportunities to improve and innovate across Tayside as much as possible. So there's a real focus there in terms of enhancing communication and engagement, of ensuring that lived experience is at the centre, and we are aiming to develop a Tayside-wide strategy. With regards to learning disabilities, in P&K, you've had previously reported to you good progress. Again, still much to be done and a great deal of consultation currently for people with lived experience, and then moving more into enhancing engagement with carers. Where appropriate, we are working with colleagues across Tayside to consider solutions specifically for those with the most complex needs and where specialist levels of care are required. So nationally, also finally, just to note, there has been a refresh of the Coming Home action plan. This has been updated and will be placing a renewed focus, which we're very pleased to see, on human rights, identification of those at risk of admission, and to strengthen the response with regards to prevention, to reduce the risk of delayed discharge and where we see inappropriate out-of-area placement. In addition, there will be a focus on better housing and ensuring that we have skilled and appropriate community support. So again, this is very much to be welcomed. Thank you very much.
Thank you, Jane. Any questions? Does the board have any questions? Maureen?
Yes, I think I mentioned at the last IGB meeting that I would have welcomed a written report rather than a verbal report, because a verbal report, we don't know what's going to be reported until we're actually at the meeting, you know, and I would really welcome, you know, in the future. I mean, obviously that nobody paid heed to that when I mentioned that at the last meeting, because we've got another verbal report. But I really would like, especially because mental health and learning disabilities have been linked together, and there's been a big emphasis on the learning disability because of the transition from you know, to Murray Royal, and rightly so. But that's coming to an end now, and it's almost resolved. So I really feel that the concentration now is on mental health services and having more services in the community 24 hours. And I would like to see where we're at there, like, you know, if we've actually progressed. Because I know that the new in Perth was opened as a crisis centre, but it just seems to be office hours 9 to 5, and we all know that you know, mental health crises don't happen during 9 to 5; they happen out of hours and at the weekends, and that's where we need to have a concentration of services. And I would really like to see a written report as to where we're at. So.
Thank you. Jane, would you like to?
Thank you. Just briefly to respond, well, I very much welcome the priority you're giving to these two particular groups, absolutely. And also note your point about written reports in the future, which I'm happy to oblige. Just to reassure you that with regards to both mental health and learning disabilities within both P&K and with wider Tayside system colleagues, there's an enormous amount of work taking place, and we hope to bring fully comprehensive reports to the IJB as soon as possible.
Thank you, Jane. Just to say that it's heartening to hear the priority that Perth and Kinross are giving to this topic. In my role as lived experience member on the National Care Service Advisory Board, some of you will be aware that coming home is a priority work stream of that group. And so it's just great to hear of the good work and, as I say, the emphasis on these areas that's been given in Perth and Kinross. So thank you.
Thank you. Any other questions? No. In that case, can we note the verbal update from Jane? Thank you. Next on the agenda is the Perth Kinross ADP annual update and annual reporting survey. Can I ask Charlie Cramner, Alcohol and Drug Partnership Lead, to introduce the report, please?
Thank you, Chair. This report provides the IGB with an update of the work of the Perth and Kinross Alcohol and Drug Partnership over the last 12 months to progress the priorities of our strategic delivery plan. IGB is asked to note this progress and request an update in 12 months' time. The report also presents Perth and Kinross ADP's response to the Scottish Government's National ADP Annual Reporting Survey. The survey reports on local delivery of national drug and alcohol policy during the financial year 25-26. IGB is again asked to note the content of the survey prior to its submission to the Scottish Government. To the report itself, the current ADP Strategic Delivery Plan focuses on 4 key local priorities. So these are prevention and early intervention, reducing the harms caused by alcohol and drugs, developing our recovery-oriented system of care, and getting it right for children, young people, families and communities. An additional 6 priorities cut across all areas of ADP work, and these include placing living and lived experience at the heart of all ADP activity, equalities and human rights, and tackling stigma. And the report in front of you describes the work undertaken and the progress made in addressing these priorities during the second year of our current plan, which ran from April 25 to March 26. So the work that's been carried out in the past 12 months includes, under prevention and early intervention, work by the partners of our Children, Young People and Families subgroup to lead the development of a whole school multi-agency education programme, which aims to reduce substance use and antisocial behaviour by embedding prevention into the curriculum and strengthening parental and community engagement. Under our reducing harms caused by alcohol and drugs priority, there's been a variety of improvement activities taking place in both the community and prison settings to increase the number of bloodborne virus tests carried out, following the introduction of a series of Scottish Government targets designed to increase testing rates. Under our developing our recovery-oriented system of care priority, there's been continuing work with a partnership with Scottish Recovery Consortium to develop a new recovery-oriented system of care for Perth and Kinross. Our ROSC is a supportive network of services that focuses on long-term recovery rather than just a focus on treating immediate symptoms. In the past year has seen a number of workshops taking place, which have included 40+ representatives from our local recovery communities and also our local services. And we're now in the process of developing an action plan, and the focus then obviously will move to implementation of the action plan. And finally, getting it right for children, young people, families and communities is our fourth priority, and the past year has seen work to ensure services meet the new standards for young people accessing treatment and support for alcohol and drugs, which were published by Scottish Government earlier this year. The impact of all this work and other work discussed in the report have resulted in notable progress being made in each of the 4 key local priorities. And some of the impacts include the highest number of alcohol brief interventions recorded in the past 4 years have been undertaken. We've seen a significant increase in the number of take-home naloxone kits distributed during the year when compared with the previous year. We've seen a small reduction in the number of suspected drug deaths, going from 19 to 18 when compared with the previous year. We've had over 90% of treatment starts within HMP Perth, with people starting treatment within 3 weeks as per the HEAT target. We've seen further progress in implementing and embedding the MAT standards, the medication assisted treatment standards, where we now have 9 standards fully implemented across a range of settings and services. And the one outstanding standard, MAT 7, we have a test of change in development across 3 community pharmacies, which will see the dispensing of Buvidal, and that will support the implementation of MAT 7. Moving on briefly to the ADP Annual Reporting Survey, which is the second appendix in the report. Scottish Government Annual Reporting Survey requires all ADPs to report on a range of services relating to drug and alcohol policy delivery during the year. The data is used to inform national progress and inform future policy direction. So further to the progress highlighted in the annual report itself, local responses to the survey also highlight the breadth of work that the ADP undertakes. This includes recovery developments and activities to reduce stigma, the range of engagement opportunities for people with living and lived experience of substance use to take part in ADP decision making, and also the activities of services which focus on adopting a whole family approach. So just to conclude, the report and the annual reporting survey both highlight the good progress made in the second year of our strategic delivery plan across all 4 key local priorities. Year 3 of the plan will obviously continue this work and will also report on specific actions. These include the establishment of pathways between inpatient and community services, continued implementation of MAT standards, but also in justice settings as well as the community and in particular prison settings, and the development of peer mentors to support service users' engagement with alcohol and drug services. Following the publication of the Scottish Government's new substance use strategy, preventing harm and promoting recovery, a significant amount of ADP work in year 3 will also be focused on the development of a new ADP strategic delivery plan. I'm happy to take questions. Thank you.
Thank you, Charlie. Councillor Frampton.
Thank you. Thank you for the report. On page 16 of the pack, it's got on paragraph 7.1.4 of the report, this details the number of ABIs delivered and the number of naloxone kits that's distributed from 2022 to 2023 and 2024 to 2025. It has now been a few years that the distribution of naloxone has been widely distributed to first responders, community partners and the public in Perth and Kinross. I would like some comprehension of the success rate of our naloxone programme. I would specifically like to see a report on the figure span in 2024 to 2025 period. How many of the naloxone kits has been used in the field? What is the success rate for those interventions? Given naloxone funding comes from the Scottish Government and local authority budgets, it would be good for us as a committee and the public to know what the verified success is. As a kit sitting on a shelf in an office is a statistic, whereas a kit used to reverse the effects of an opioid overdose is a success. If we are saturating our streets with naloxone kits that are expiring on shelves, then we need to know the efficacy of this intervention to determine if this path is effectually saving lives.
Thank you. Charlie?
Thank you for your question. It's a very good question, a very interesting question, and a very difficult question to provide a definite answer for. It isn't possible to have a model where there's a very neat distribution versus administration success metric that we can produce. There are a number of different strands of data that we can use to get some idea of the success of the naloxone programme. Just to give you a couple of examples here, our radar rapid action drug and alcohol alert system reports on quarterly Scottish Ambulance Service naloxone administration. So we can get some data from the amount of naloxone kits that SAS have administered. And that will include multiple administrations as well, because as we're seeing with some of the new synthetic opioids on the market, it requires more than one naloxone administration to reverse their effect. So we can get some data that way. We can also look at our near fatal overdose incidents, and that will also give us some indication of the number of naloxone administrations that they've been. So there's a couple of options there. What it doesn't provide is a full picture. And that's problematic because if you develop a set of stats that doesn't give you the full picture, people obviously tend to just look at that number and think that that is the full story. Obviously, there are issues in recording the number of naloxone administrations that are not by SAS or incidents that are not reported to SAS. So there could be naloxone administrations carried out by friends and family that we never know about. So there's always that danger of under-reporting. I think it's fair to say, though, that because we do have near fatal overdose data and the other data we've mentioned, we can confidently say that naloxone distribution is saving lives. And there's clear external evidence for that as well. But that difficulty in reporting definitive numbers on a local level, unfortunately, remains. The final thing I would say as well is there is a push to try and look at publicly available naloxone that's different from simply a mass distribution of kits. So we looked at this ourselves locally. We ran with an idea of trying to put naloxone in defib boxes. And unfortunately, although that idea was quite well received, it proved to not be possible to do because the defib box access is controlled nationally, and there was a whole lot of complications around being able to do that. There are other options, and there's a test of change in South Lanarkshire, I think, where there's been a standalone naloxone box developed for public access. So that and perhaps other options may offer different opportunities beyond the mass distribution of naloxone that you're referring to there. But I hope that answers your question.
Thank you. Okay, Martin, Heather.
Thanks very much for the report. You mentioned in your overview there about the alcohol brief interventions and the increase in this particular quarter and the 58% increase overall. Is that due to people being more aware of the support that's available, or is there another reason for that? Are you able to give us any further information on that? Thanks.
Thank you. So we have a pan-Tayside ABI coordinator, so it's funded across the 3 ADPs, and her role is to try and encourage lots of different sectors to carry out ABIs. And I think what we're seeing here, it's taken a while. There's been a lot of work, there's been a lot of training, a lot of education, but we're starting to see the fruits of her work in trying to increase those number of ABIs. Again, something else that's difficult to measure. Often we rely on just returns coming back to a central area to record the numbers. So there's probably undercounting of the number there as well, but that undercounting will be consistent across quarters rather than an anomaly. So I think definitely we can point to the work of the ABI coordinator to keep pushing, to keep trying to make sure that where there are opportunities to carry out ABIs, that they are actually being undertaken.
Yep.
I think just for me as the reader of this report, it would have been quite useful to have a wee bit more information about that, because I thought, well, this could be a big success because we could actually be engaging with more people because of your coordinator. But I think it would have been good to have just a wee bit more information there in the next iteration. Thank you.
Thank you, Heather. Martin?
Thanks, Chair. I have a couple of questions, if it's okay. To the annual reporting survey. Firstly, there's a lot of good work getting done at Perth and Kinross, and the ADP has to be congratulated on that, but there's still a lot that needs to be done because people are dying. That's the bottom line, they're dying. But in section 1 it says, do families have an option to be involved in alcohol and drug death review groups? And you've got no. Well, obviously you can't because you didn't have an alcohol and death drug review group, but you've got a drug death review group. So why are people who are living with the addicted person not being involved in putting their experience into a review on drug death? And the second one, have you made specific provisions of any protocols in the past year in response to the emerging threat? There's always got to be emerging threat. You know that. Emerging threats are all the time. And again, they've answered no. So we're playing catch up there. That's the first couple of questions on one page. Here I've got another. You're fine with new ones first.
Thank you. Yep, I'm happy to answer these two initially. So we do have a pan-Tayside drug death review group, which is a multi-agency group. We haven't at the moment included families in that. That's something that the group has considered and will consider again. Over the past year, we've had real problems with trying to get data that's been on time. There's been big delays with drug deaths information. There's been toxicology report delays. And for the past year, the group's been trying to catch up so that we're able to review cases in a more timely manner. I think we're there now. Those delays have lessened and they were national delays that we were experiencing. So I think that does open up the opportunity to look at that again. We have a new public health consultant in substance use, Victoria Stanford, and I know that as part of her role, she's keen to review a number of these different groups and systems and to have a look and see if there's any improvements. So I'm happy to feed that back to Victoria and have that as something for consideration. So thank you for that. Your second question among emerging trends, you're right, it is really difficult. There are new substances on the market all the time. There are substances, particularly things like synthetic opioids. We don't know what they are. The tests don't detect them. Eventually a test will, but then by that point there's something else. So I think sometimes the answer may be, rather than focusing on specific substances, it's actually to make sure that we've got general pathways to support people almost for whatever substances are involved, particularly when we see very much a common trend now of polysubstance use. Very rare that someone's taking one substance. Often there's a range of substances. We know that, for example, in our drug death group, the average range of substances that we see is 5, but sometimes we see anything up to 13 or 14 substances that someone's taken. So I think focusing on individual substances can be problematic. I think it is more about having that more general help and support available and making people aware of the pathways that exist rather than perhaps the ketamine thing or the cocaine thing, because in 6 months' time, it could be something else.
Thank you, Martin. Did you have any other questions?
People most at risk having access to treatment and recovery, and there are a lot of bold people identified in that. That's on page 61 and 284. But unfortunately, primary care is not. And when I go over the page, to another thing, challenges engaging with GPs. And how do we break down this barrier? Why is this happening? Because I would have thought it was the first place that if you're having a problem, you're going to get support and help. But in primary care and GPs, we're not.
Thank you. It has been a real challenge through our MAT standards work. We'd hoped to be able to engage with perhaps a lead GP, and there was a lot of efforts across the board to try and do that. We did have a specialist GP at one point who unfortunately retired, and we haven't managed to find a replacement. So as a result, our work around MAT 7 has tended to focus on community pharmacies rather than GPs, and we've managed to, as I said earlier, we've managed to develop these tests of change, which will look at Buvidal dispensing through community pharmacies, which is a real positive, and that work's being replicated in Dundee and Angus. We do have good engagement with GPs in terms of, we find that our patients or clients, while they might be engaged with IDART for their substance use issues, they are also engaged with GPs for other health issues. So in that sense, we do have that shared care, but where we're lacking is that real GP engagement in the substance use element of things. It's something we'll keep pushing. It's something we'll keep trying to do, but obviously welcome any suggestions and support to help us to be able to do that.
Martin?
One is about the brief intervention. That did my head, brief interventions, like it really did. Because it tells us we've had a brief intervention. It doesn't tell us what is the outcome. Where is that person went in life? How have they went back to society? Are they taken out of society? It tells us nothing, but somebody said after 3 weeks, hello. And it's a MAT standard. I don't think the Scottish Government actually want them filled in there, like, but brief interventions, we need to start to see evidence, and I think Councillor Frank was talking about that with Oxford. We need to start having the evidence. What is the impact of these interventions? What's the outcomes of these interventions? How are we supporting the person involved in these interventions? And there's no evidence in this report showing me that way.
Thank you. Yes, it is a common challenge with ABIs. As I said, even to work out the number that are being carried out is very difficult. There's no central database that people feed into. We're often just relying on reports coming back. And as you say, a bit like naloxone as well, there are gaps in terms of determining how successful these things are. We know there's a general body of evidence to show that ABIs are effective, but that local information to see the effectiveness would be really useful. So yeah, I would agree that we need to do more around trying to establish the effectiveness of some of these things that we're doing. There's a lot of things being done, and I think the report perhaps reflects some of that, but sometimes it does feel as if we're trying to do everything. And I think sometimes a more focused approach on certain things and a bit more concentration on the effectiveness of these things would actually be beneficial. And I would hope that as we move forward into our new plan, that's something that we can focus a bit more on, particularly because the focus there is alcohol. And obviously in the new government strategy, there's a clear directive to focus on alcohol in addition to drugs. And that's something that in the previous plan, there was more of a focus on drugs.
And lastly, talking on page 58 about the implementation of Summer of Hope, a great idea. What has actually happened in that? And one of the positive messages I would be put out is being addicted is not a lifestyle choice. And then professionals start to understand that addiction is not a lifestyle choice. Losing your family, sleeping in the street, being unemployed, being ill, that's no lifestyle choices that I want to take. Believe me, so we need to get out of this stigma that addiction is a lifestyle choice. Thank you.
Thank you. That was an easier one at the end. So Summer of Hope, that it's been developed by a new recovery officer, who's a new member of the ADP support team, which brings us up to 3 members of staff. But we are really keen in the ADP to emphasise recovery. That's something that just isn't talked about. We talk about treatment, we talk about harm reduction, but recovery is so important. That's why we're developing our ROSC, our recovery-oriented system of care. The message is that people can and do recover. And we're often asked, are you running an anti-stigma campaign? You know, are you doing this sort of thing? This is the sort of anti-stigma work that we're doing. We're trying to get the message out there that there is hope. There can be positivity. There's a lot of activities planned. They're still in the planning stage. There's new things happening all the time. We've got gala days. We've got foot golf. We've got an art exhibition. We've got a pool and darts tournament. We've got various different things across all of Perth and Kinross, so not just in Perth City. We've got another gala day in Crieff, I think, the stuff going on in Blairgowrie. So it's really just to try and spread the message and to send that positive message around recovery, rather than maybe some of the media headlines that you'll often see around substance use. There is another story, and it is a positive one, despite the challenging circumstances that we find ourselves in just now.
Thank you, Charlie. We're going to move to David Illingworth, Councillor Illingworth.
Right, thank you. You talk about changing patterns in drug consumption, like synthetic opioids. What's driving those changes?
I think the ability to produce them, the ability to make money. There is a huge market, and it's an international market around drug distribution, drug networks. If people can make money from making something very cheaply, and synthetic opioids can be made very cheaply, but at huge profit, that's really the driver. It's the market. Sad to say. And while we've seen reductions in the availability of heroin, for example, particularly during COVID and then beyond, the market replaced that with something else, and it replaced it with things that are cheaper and more readily available. And that's why there's such a difficulty in, if you like, trying to get on top of it, because it's an international situation, although synthetic opioids can be produced quite easily in many different ways. So the market forces really are the reason we're seeing the change.
Thank you. Councillor McCall, please.
Thank you. So my question is really more about wider addiction services, because just as you'll find that people who have addictions to certain types of drugs or alcohol, they probably also have other related addictions, such as gambling, or in some cases they're hoarding. And so I'm just curious as to how the Alcohol and Drug Partnership works with other services within either NHS Tayside or within Perth and Kinross to be able to link those things together, because one's sometimes a causal effect of the other. I just don't see that in the governance statement that you have about the partners that you work with. So perhaps you can give me a wee bit of an update on that. That'd be great.
Thank you. Yes, we do. We work across a number of different partnerships, and we try and engage with as many different partnerships and services as we can. So we've got very close links with Justice, for example, the Justice Partnership. We're about to begin some work with the Violence Against Women Partnership. We're also working across housing as well. We've got housing representatives. We do work with the Welfare Rights and Benefits. And basically, it's about looking at the person as a whole. I think the days of substance use services trying to do everything themselves, thankfully, has gone. That's not possible. So we do, where possible, try and work in partnership and in a multi-agency way as much as possible. I think treating the addiction is only one thing. We need to look at the reasons for that, and that's when we will work with our different colleagues, both in the statutory sector and in the third sectors as well. So it really is where possible, a multi-agency approach. It's difficult because we still, in many cases, exist in silos, but we're trying to work across those silos. We're also trying to use the funding that we have available to engage with other services in joint work. So we've got some projects with the Justice Partnership where we have joint funding for different posts, and we've used that model in other areas too. So I think it's a developing work in progress. I wouldn't say that we're there. I wouldn't say we've got it right yet. But there's certainly an acknowledgement across all our partners that that's how we should be working, and there are certainly drives to do that.
Thanks, Charlie. That's really helpful. I do know that sometimes addictions to gambling, for example, can be as a consequence of an addiction to different types of substances. And somehow that seems to be left out on its own. It's not necessarily a cause. It's often interrelated, and indeed very often they're mental health issues, as Martin has educated us all very well on, that addiction is a mental health issue, or can be. So I think when the new strategy comes out, it'd be quite helpful to be able to see how that interfaces with these wider addictions that affect people. because there's a cause and effect, and to try and address just an alcohol or a drug addiction without understanding the related circumstances that people live in, it's not the whole picture. So I think that would be really useful to have that going forward. Yeah, that's the main thing, really. Thank you, Charlie.
Thank you. Just to say, I would agree, and often I think one of the buzz phrases at the moment is or buzzwords of complexity, and there's this understanding that people live complex lives. I don't think it's complex. I think it's just life. And I think we have to, and I think we do recognise that in the ADP. I think sometimes we can get tied in knots talking about complexity, but people very rarely have one issue, no matter who you are, or no matter who your addiction, or if you don't have an addiction. So it's acknowledging that and making sure that we work with the right services to help people with the range of different issues that they may have, most of which may not be particularly uncommon either.
Sorry, I just forgot one thing. Also missing from the ADP governance section on page 14 is any reference to adult or child protection committees. I know you work with them, but I think they need to be part of the multi-agency team as well, because they do have very specialists, particularly in the police, very specialist officers, been able to deal with some of those things. Thank you. Thank you, Chair.
Thank you, Councillor McCall. Aaron.
Thank you, Chair. Yeah, I suppose just to note that Charlie, as part of the ADP, is also a core member of the Public Protection Coordinators Group as well, where we have colleagues from Child Protection, Adult Protection, Suicide Prevention, Gender-Based Violence and MAPA in attendance. So we are always looking at opportunities for kind of collaboration and cross-working to avoid duplication of work. And I know Charlie's just mentioned there kind of working alongside suicide prevention and colleagues from gender-based violence, and the initiative that we've spoken about here in Blairgowrie also alludes to some of that kind of joint work that's been done as well through that collaboration as well.
Sorry, just to be clear, I'm aware that all of this is going on. It's just not included in the report, and I was hoping that when the new strategy comes out, this one will last till 2027, that it will be more, explicit and perhaps explain more how that multi-agency work will do, particularly when it comes to prevention. Thank you.
Thank you. Councillor Grant-Stewart.
Thank you, Chair. I was wondering about alcohol-related deaths. Do we know the figures and why is it not in this report?
Alcohol-related deaths is always a more difficult set of data to provide because unlike drug deaths, there's a trigger there. Whereas alcohol-related deaths can be for a variety of different causes, and therefore there's not that immediate trigger which allows us to count. What we do have our analyst team who will look at this though, and they will produce data where possible. They're just about to produce the Perth and Kinross local area profile for substance use, which is an annual piece of work, and that will include, where possible, the data that they can pull together for alcohol deaths as well. So we do have some measure of it, but it's difficult, I think, to have, again, I talked earlier on about not having a complete data set because there are things that we can sometimes miss, and I think this is one of these occasions as well where we have some data but we don't have the complete data set. But in future we'll be happy to include some of the information that we have, if that would be helpful.
Councillor Collins-Stewart.
Thanks, Chair. I think maybe two questions, but on very different subjects. The first one is looking at the survey return. In section 1, the third question is, do families have the option to be involved in alcohol and drug death review groups? And the answer is no. And I would have thought that would be a key. Am I missing something?
Sorry, Colin, that was a question Martin asked earlier on.
Sorry. Okay. I thought it was a different review group he was asking about. Okay. So the other question was, it's just been mentioned that the reporting survey is the strategic delivery plan is until 24-27, and we're going to get an update in 12 months' time. Presumably there'll be a refresh strategy next year. I was just wondering, in terms of some of the comments that, or some of the questions that people have been asking, in terms of the metrics that we're using to report on, the metrics all seem to be the ones that come from government. And some of them are activity related rather than outcome related. It's something that I notice, we were discussing at the Community Planning Partnership Board a couple of weeks ago, where very often you've got sort of proxy indicators, and I know what you're saying in terms of it might be very difficult to work out the number of successful naloxone interventions, as opposed to it's easy to work out the number of naloxone kits delivered. But I just wondered whether there's a danger sometimes, maybe this is more of a comment than a question, that we're using more proxy type indicators in terms of measuring the success or measuring the outcomes of a delivery plan, rather than actually, you know, how many people have we helped into recovery, and that has been sustained, you know, over 12 months, over 24 months, over 5 years, whatever it might be. You know, the actual health outcomes that focused on the individual.
Yeah, I think we need to have a more rounded data approach. I think that would help. I think there's often a focus on just the quantitative elements of it, and sometimes they maybe don't tell the full story. Our MAT standards work, I think, it's helped us to look at things differently. There's been a big push through MAT standards to make sure that we get the voice of people with living and lived experience. So there's been a lot of work around the qualitative element. And I think in the new plan, we need to do both. We need to make sure that we've got good measures, both quantitative and qualitative, and then good outcome measures as well, so that we can really tell the full story. It is obviously, it's difficult in a sense, because if you want to measure recovery, then everybody's recovery journey is an individual thing. Average recovery can take about 7 years, so that's obviously difficult to measure in a report. But I think we can do more to try and tell the story than we maybe did in the previous report. And as I say, I think if we use our MAT standards work as a foundation for that, we can produce something that's more informative in the future.
Thanks, that's helpful. And just in terms of approving a strategy in presumably 12 months' time, would there be the opportunity for the board to have a discussion about that at an earlier stage, so that, again, we're not getting to, as I was indicating with the primary care strategy, we're not getting delivered a thing which we haven't had input into the shaping of?
Yes, is the quick answer. So the new strategy, we'll look for sign off both from the ADP strategy group and from yourselves as well. So we'll factor that in so that it's presented in a timely way for allow you to do that, to feed in, and then for us to take that feedback away and produce a final version. So yeah.
Thank you, Martin. I'm conscious of time, so one last question.
It's actually on the deaths from alcohol. A lot of people don't want alcohol on the death certificate, and that's part of the reasons why you'll not get that information. But the fact is that we need to start understanding why does it keep rising? Why are alcohol deaths rising and rising and rising and rising? They think they've ever went down. And so what is the problem that we're not addressing? And I do think we've got enough information in the data that we're provided to see what are the outcomes on helping to slow that down or stop it.
Thank you. Yes, but it is a huge challenge, and I think one of the positives in the government's new plan is that recognition of the importance of looking at alcohol as well as drugs. It's something we've maybe struggled to do because there's been such a push towards drugs, but we do have to have a bigger focus. The numbers can change on an annual basis, but you're right. Overall, it's high. It's too high. It's high for a lot of reasons that we don't have time to discuss in detail here. Culturally, we obviously have a massive problem, and that's ADPs alone can't change that. As a nation, we need to look at what we do there. But there are things that we can do, and I think the next focus, and that our new plan will allow us to do that and try and make some inroads into those numbers.
Thank you. Thank you, Charlie. Can we, I'm conscious of time, can we note the report and the recommendations? Yeah, thank you. Oh, sorry, Maureen. Apologies.
Yeah, I was looking at the priority now. Granted, they're historical, they're going back to 22-23. I suspect they'll be just as bad, if not worse now. And it's highlighting the proportion of Perth and Kinross secondary schools where there's a lot of drinking going on, and how I don't know how they're dealing with it. Then risk number 2 here is the reduced, the average alcohol-specific deaths are, I don't know if they're actually going down. Somebody mentioned that they probably were, but I wonder where these figures are from, because I've heard of, a few deaths recently, and also the use of preventive medication rather than dealing with the problems, and offering rehab. Maybe it's because it's too expensive, I don't know. But the methadone program seems to be heavily relied on, for maintaining, addicts, and I wondered how often they look at some. I know some of them have been 15 years plus on methadone, which is addictive as well, So I don't see that as a cure or even dealing with the problem. It needs to be, something other than putting them on, a program to maintain them.
As a result of the MAT standards, there's been a big focus on alternatives to methadone, and what we've seen are annual increases in the use of Buvidal and buprenorphine, which does allow people, because often it's administered on a monthly basis rather than a daily basis, then it does allow people the greater freedom without having to attend a pharmacy every day. So we've seen the numbers increase there. We still have people on methadone, obviously, but there is that movement over the past few years, and that's something that looks like it will continue. So there are efforts to try and change things. It's difficult to change things quickly, I'm sure you're aware, but that is certainly a positive outcome, and that's come from the MAT standards. It does come with an increased funding cost. Buvidal and buprenorphine is a lot more expensive than methadone, but thankfully we've been able to support the provision of that and the continued provision of that despite the increase in numbers, and that's something that I hope we can continue to do, because using Buvidal has produced a lot of positive outcomes, even with some people who have been particularly chaotic and have been quite difficult to engage in treatment. We've found that the use of things like Buvidal can actually be really positive. So that's something that I'm sure we'll try and continue.
Thank you, Charlie. Sandra, take one last question if you have one.
There we go. Thank you. I just wondered if there was an opportunity to link into some of the data collected around minimum unit pricing for alcohol, which is much talked about, the data and the effectiveness of that to get information around alcohol deaths. Just a comment.
Minimum unit pricing is quite new, and I think we'll really only see the impact of that over a longer period of time. I know that at the moment the main piece of evidence comes from some modelling of what we would expect might have happened had there not been minimum unit pricing. So that provides one piece of evidence. However, I think it is that longer term data that will really determine the effectiveness of that or not. But it's another data source, and I think out there are a number of different data sources that we can use. I think despite the difficulties in looking at alcohol deaths on their own, I think if we can bring together things like the data around minimum unit pricing, things around alcohol deaths, things around treatment, and a number of other stats, and I think we can build a picture of where we are and the sort of things that we can do, which might determine the effectiveness of some interventions. So it's not straightforward, but I think, you know, there are things that we can certainly look at. Also the impact of things like alcohol marketing as well. I know there's a big focus from Scottish Government coming up on things like that, advertising, marketing, placement of alcohol as well is something that will be looked at. And again, there'll be measures that come with these different interventions, so that the key will be trying to make sure we've got good measures around these things to build up that overall picture.
Thank you, Charlie. So we'll move on next to the CAST medical evaluation and lessons learned. Can I ask Sal Peterson, primary care lead, to introduce clinical lead to introduce the report? Thank you.
Every time. Thank you ever so much. I have got Lisa Milligan as well, who's online, and I'm hoping she's going to be able to answer any of the hard questions. I hope you found this quite a positive report. The first thing that I'd like to see, even though this is a short report, I would really like to thank everyone who is involved with the work around this. Lisa, without doubt, was fundamental in all this work, as was the rest of the primary care team. But I think I also have to extend my thank you through to the other health and social care partnerships that were involved, the primary care and NHS Tayside, the local GP practices who are brilliant at expressing their concerns, giving us ideas and the risks that were involved, and also particularly to how well the new provider, Deutsche Williams, has in engaging and providing a service within CAST. So you'll notice that there were two key elements to this paper. The first is particularly about the CAST practice transition. And overall, this has been a really positive and successful outcome. Following the termination in September, due to workforce sustainability challenges, a new provider has been appointed and the service transferred safely without any disruption. 6 months on, the position is stable and provides good assurance. Patient numbers have remained stable. There's been no disruption to care, no complaints, no patient safety concerns reported. The workforce has been successfully re-established and with improved resilience in key areas, particularly in the administration team. Services have not only been maintained but enhanced. We've now got more care being delivered locally, with reducing the need for patients to travel. Governance arrangements are in place and early quality and safety indicators are reassuring, although formal performance data is still developing because 6 months is actually quite early in the scheme of things. Obviously, there are ongoing considerations that we need to consider. You'll all be aware of the significant issues and concerns around the premises, but we can continue to explore those, particularly in collaboration with NHS Tayside and the new partners there. And also there is some continued embedding that's needed, because despite the fact there's been taken over new practice, they've also moved on to a new IT system, which has been very successful so far, but will need some more embedding in. With regards to the lessons learnt, this was reviewed by all key stakeholders that were involved and highlighted quite a few strengths in how this transition was managed. This included early coordination planning, strong partnership working, effective community engagement, and a transparent procurement process. They were key to achieving a smooth transition with no impact on patients. But however, with all these things, there is room for improvement. And I think we have to identify that our areas of improvement were not about the people who were involved. We worked really well collaboratively, but I think we have to recognise there is a complexity to this process that there is always room for improvement. And this particularly included the need for greater clarity around governance and roles. I think we needed more sort of coordinated communication with stakeholders. We had some great communication. I don't want to take that away. Colin was there when we had the meeting with the public, which I think was really successful, but I do feel that we were maybe feeling our way, and we've learned a lot around the communication and what benefits our stakeholder, and also the stronger use of structured action planning. And most importantly, these actions are already in progress to address these areas, and we're working collaboratively with the primary care at NHS Tayside to make sure that we've got those standard approaches to communication, clearer governance pathways, and more consistent processes. I was going to say future transitions, but fingers crossed we never need this again. So in summary, this represents a well-managed transition with a stable current position alongside clear and actionable learning to strengthen future system responses. Thank you.
Thank you, Sal. Colin?
Thanks, Chair. Thanks, Sal, for the report. And I know that there was a huge amount of work went on at the time. But one of the things that we did commit at the time was to lessons learned, and that's why this has come back today. So thank you for doing that. It was just there's a primary care at the very end. Primary care services confirmed all the recommendations for future improvements are currently being reviewed or completed. I just wondered what the sort of tracking, monitoring process for making sure that all of those 7 recommendations, I think it is, how that we capture them and progress.
Yeah. So a lot of them will be linking through, and it's kind of sort of complicated because some of the recommendations are being led for in other short life working groups that we're underseeing. So with some people are looking at sort of the model of 2C, and some of that will come under that. A lot of this will be presented at the at CCT, where we actually discuss, which is one of the meetings that we have fortnightly with all the stakeholders, and so that we're able to engage and actually see where things are progressing. Much of this work has already been done, and it's already in, it sounds awful, in like a shelf, so we can just pick it off should it happen again. So it's already there. We're in regular contact with Rachel Benison, who's the primary care manager for NHS Dayside. I think I've got her role correct, and she's in charge of sort of updating things regularly, and we've got really good links with her to know what's been progressed and what not.
Thank you. Lindsay?
Thank you. Yeah, I agree. I think it's really good to see a lessons learned document in regards to what you did well and what you didn't do well. Looking at the engagement aspect for public and staff, I would always be welcome to be included in Perth and Kinross as the lead staff side for NHS Dayside. I think we did have conversations, and I'm in a lot of things. Okay, so please bear with me with that. However, going forward, if this was ever to happen, I think this is a good piece of work that people from other areas within primary care could look at in regards to a transition, because with the primary care strategy coming, I would assume that there may be potential for a lot more change there. But just to say well done and happy to help if it happens again. Okay, happy to help.
Thank you. Danny?
Thanks. Yeah, I'd just like to highlight just how complex this work was. I think on this occasion, having another provider come in to take over that care was obviously the preferred option, and has really helped make things as seamless as possible. And we shouldn't diminish the amount of work that still takes. From the patient's point of view, everything seems like it's just gone very straightforward, and there's potential enhancements to the care now. I suppose my anxieties here are around the issues that led to that those partners handing back that contract, and I think a number of those factors have still not been addressed. So primarily the premises situation, the location, the geographical location, and the size of the practice, and those are probably going to remain sort of the issues that leave that practice vulnerable. And so I suppose the question is there anything that this board can do to try and help address that?
I think this is a real difficult one, because a lot of those, the issues that you raise are actually issues for every single general practice throughout NHS Tayside. So I think very much we concentrate as the primary care team very much on sustainability, and you'll be aware that you'll be aware because you developed it. The sustainability survey, we've just had the response, and they're just being analysed. Obviously, you also be aware of the complexity of where things like premises lie and whose responsibility that is. And we liaise quite very closely with NHS Tayside around those issues, particularly, and also liaise with our local practices, whether that's CARS or some of the other practices, to consider the risks that are there. But yeah, I agree, it's really complex and it's an ongoing issue.
I'm not aware of any other practices working out of porta cabins at the moment. I take that point. I think part of the issue as well with the CARS is that a large number of their patients reside within a boundary that is not covered by any of the practice. So again, that does leave them vulnerable. And whilst I hope the new provider will continue to provide services, their ability to expand and make that service profitable and viable, which I guess is why they've come in to take that on, is significantly restricted.
Maybe answer this, because I think they've already extended their boundary. I think also when we looked at it, you're absolutely right, there is a very small area that that is only covered by CARS. And I think we recognise that this is an issue for a lot of practices. We only have single practice in a lot of key areas, whether that's Comrie or other outlines. So this isn't just an issue for CARS, this is something that we've got to consider may affect the sustainability of all our practices throughout Perth and Kinross.
Thank you. Thank you, Sal. We'll go Martin and then Sheila, please.
Thanks, Hal. Really good report. Could you clarify for me, it's on page 78, it's define the voting rights and representation for the option appraisal exercises. Could you define that for me a wee bit?
So this was really complicated because although the practice was in Perth and Kinross, we also then had, so we had the Perth and Kinross issue, but then we also had Dundee practices who had involvement because their patients came down to CARS. We also then had NHS Tayside Primary Care overview, and we then also had Angus involved as they've got the lead partnership. So I think it was more, I think we got it right in the end, but it's just having when this has happened before in other places, we've maybe not had the huge complexity because we've had 3 health and social care partnerships, rather than there's maybe just been 2 where things have happened in Dundee and we've just had Angus. So I think it's about incorporating and understanding the complexity that may be different from other situations when this has happened early on. And I think overlooking now, it's easier to see the differences, whereas you step into it. I think we stepped into it very much at the time thinking this is very similar, so therefore we know what we're doing. But actually there was added complexity to this that we'd need to consider and would in future be more adept at considering.
Thank you. Councillor McCall.
Thank you. I didn't think it was complex at all. We had patients and members of the public with the possibility of not having a general practice provision. That's what should have driven everything, to be honest. That's just my observation of it for what it's worth. My comment that I wanted to make actually was to say well done to everybody involved in this. I do know it's a huge success. I really like the idea there's lessons learned. I think, you know, working on this, I think there's an opportunity to develop almost a blueprint so that when we've had several cases in Perth and Kinross where, you know, satellite practices have closed down, we've not really been able to respond properly. And then there's huge tranches of our rural communities in particular with no GP provision at all, which consequently has put, you know, additional pressure on the practices based in the city. So I think I welcome the lessons learned report, and I look forward to seeing some sort of quick operating model that means we can, you know, take the lessons learned, spring up much more quickly, and and simplify the complexities that arose in this particular case. So I don't really need an answer. I just want to say well done, and it's a huge success. Thank you.
Thank you. Thank you, Councillor McCall. Thank you, Sal. If there are no further questions or comments, can we agree the recommendations in the report? Thank you. I propose we'll take a 10-minute break now before we come back for the verbal update of the strategic planning group from the Chief Officer. Thank you. Welcome back. Can I just, before we start, remind people that the meeting continues to be broadcast, and we'll take the next point, 5.6 strategic planning group update. Zoe, can I ask you to provide an update, please?
So I'm providing the update this particular meeting, but moving forwards, it will be the public partner co-chairs that will provide the strategic planning update for us. We met on the 12th of May and considered 2 substantive items. So there was an update in the Perth and Kinross 3-year workforce plan, 25 to 28, and the Tayside Together Palliative Care Matter strategy that we've already heard in this session today. The discussions that were held provided assurance that both areas are very aligned to our key system priorities, including workforce sustainability, whole system planning, person-centred support, community-based support, partnership working, and improved outcomes for people, unpaid carers and communities. So members noted significant workforce pressures arising from demographic change, increasing complexity of need, our ageing workforce, recruitment challenges and growing retention risks, and noted that the plan's structured response to the 5 pillars: planning, attraction, stability, training and well-being, looked to be identifying a robust measures for dealing with some of the complexities facing us. The group welcomed the direction of travel and emphasised the importance of improved workforce data, flexible role design as a potential to expand our use of existing workforce, stronger links with schools and communities, inclusion of the independent and third sector partners, and a more coordinated approach to valuing health and social care careers. The group also received, as I said earlier, a presentation on the palliative care strategy. Members again supported the strategic direction, particularly its emphasis on early, holistic and person-centred palliative care. The importance of families, unpaid carers and communities and third partner sectors in this work. Discussions highlighted a few areas for ongoing improvement, so clearer recognition of the care home sector in this work and the specialism that they already hold and continue to deliver with. Improved education and training, particularly in relation to future care planning and consent issues. Bereavement in schools was discussed, and a new charter that's been developed by the Scottish Partnership for Palliative Care in Schools, and deans who spoke to the strategy said they would be happy to come back and present in more depth detail in that, as the group were particularly interested. And of course, ongoing and better coordination across Tayside will be a key measure for us. Another area of discussion was the inclusion of engagement with underrepresented groups. Perth Autism Support sit in our group, and they were particularly keen that neurodiverse communities were engaged with this strategy. So key issues from the strategic planning group to the board were that we need to be aware of the workforce risk, which we are through our workforce plan, the need for sustained cross-sector action, and the importance of ensuring that the palliative care strategy is translated into clear local delivery priorities.
Thank you. Do any members have any questions? Martin?
It's still not clear in my head. My understanding, and I'm talking to you, but my understanding, the strategic planning group puts together the plan for commissioning that has to come to the IJB. And that's my understanding, the role of a strategic planning group in the integration setup. And if that being the case, is there any plans coming forward from there for commissioning? And the commissioning, obviously, because the directives to NHS Tayside or to the Kinross Council.
So, as you'll be aware, the Strategic Planning Group is a legislative requirement and is primarily an advisory group as opposed to a decision-making group, and the IJB is our decision-making group. They have a specific role in terms of ensuring that the strategic plan that we have for the partnership is doing what it articulates that it is going to do. I view it always as the strategic consultation forum. It's made up of a broad membership and a prescribed membership that we need to fulfil in terms of public partners, carers representatives, representatives from across the different service user groups, representatives from the localities, and often the chief officer, chief finance officer and others as relevant. The membership of the two groups can be shared, and in actual fact it's encouraged that membership of the strategic planning group and the IJB do to some extent mirror each other. They shouldn't be exact mirrors of each other, because then you start to become, it starts to be difficult to delineate between the decision making of the IJB and the advice that the strategic planning group then gives the IJB. So in terms of a commissioning plan, there is a new plan or a new strategic plan due for 2027. That work will need to commence. Officers within the partnership will commence that work. The first thing that we'll need to do is the update of the Joint Strategic Needs Assessment in consultation with public and the workforce. And at early stages, we will take that through the strategic planning group and consult with that group, because it does represent all of the areas of delivery, for example, learning disability, mental health, drug and alcohol, etc. And that's an iterative process, and the strategic planning groups support that work, as opposed to writing the strategic plan as such, although they have the responsibility to ensure that it's in place and that it is doing what it says it will do. And advise the IJB, for example, if there are areas of work that the strategic plan isn't covering adequately or isn't able to fulfil through the articulation that's within that.
Thank you. Any other questions on this paper? Nope. Can we note the update, please? Yep. Thank you. Next on the agenda is finance. Can I ask Donna Mitchell, Chief Finance Officer, to introduce a report, please?
Yes, of course. Thank you, Chair. I'm pleased to introduce this report on the month 12 outturn position for 25-26. And this is the fifth and final finance report for 25-26. I'll keep the introduction to a short overview of the key messages, and that should allow you to support you to note the report today. But before moving into the financial position, I would like to confirm that the unaudited annual accounts were considered by the Audit and Performance Committee earlier this week, and these have now been submitted to Audit Scotland. I would also like to note my thanks to the Health and Social Care Partnership teams for their work in managing and reporting on the position across the year, and for their support in delivering on the financial recovery actions. And also to this board. It's been a particularly challenging year financially. Seems to be a common theme for us recently, and it's not going to get any easier, but we have had quite considerable scrutiny and challenge, and I would thank you as a board for your support and your patience throughout the year when we've had to consider and make quite difficult decisions. Turning to the overall position, the final outturn for the year is an overspend of 3,345,000. This will reduce, or has reduced, to 3,181,000 after the application of all IJB remaining general reserves, which therefore this overall 3.181 million represents around 1.1% of the total budget. And of that final outturn, 2.8 million relates to social care-led services and 368,000 to health-led services. And the position, as you'll have gathered from the report, has improved from earlier projections within the year, and that's through delivery of the financial recovery plan and other movements. So it has delivered an improvement overall and ahead of our original target. In terms of the key movements since the last report that the board considered, there has been a positive shift, particularly within older people services. Care home placements have reported an improved financial position alongside care at home, where expenditure has reduced compared to projections provided earlier in the year. However, it is important to recognise that particularly within care at home, although there is a financial improvement, this is partially reflecting an increase in unmet need over that period. Within the care home placements, there's a few factors there, but we have seen fewer new placements than expected, and placement numbers have decreased overall throughout the year. There has also been a change in the balance between fully funded and self-funded clients, which has led to a reduction in projected expenditure. Overall, the IGB position continues to be largely driven by demand and complexity within social care services, alongside workforce and other cost pressures within health services. In addition to the IGB's position, the report highlights a contribution of £1,180,000 to the Tayside Inpatient Mental Health and Learning Disability Service, reflecting the current governance arrangements and a share of the overall overspend within those services. The report also includes an update on the 26-27 budget position, noting that the NHS Tayside budget has now been confirmed, and I can confirm that it reflects the core funding assumptions within our own IGB financial plan, with some elements such as the reduced working week funding, they are still to be finalised. And finally, the report sets out the ongoing financial risks, including the structural gap between demand and available funding, and confirms that financial recovery will need to continue, as I'm sure you'd expect, into 26-27, but with an increased emphasis on budget accountability and financial control and financial governance. The recommendations are therefore for the board to note the final outturn position, the actions that have been taken during the year, and the ongoing work with partners to manage the position going forward. And I'm happy to take any questions.
Thank you, Donna. Any questions? Dave?
Thanks, Donna. Clear report as always. Well done to you and your team. A couple of things, unsurprisingly, it's around older people in Section 7. So I'm working with some of the colleagues within the partnership to try and make the provider forums more data driven. Now, care at home, we've been doing that all year. Care homes, we haven't been able to get information on that. So it's interesting to say there's stats and there's a downward decline in placements. That's what we're seeing on the ground from providers. We're hearing that there's some struggle with sustainability issues. It's not just because the partnership's not placing, there is other issues. So I'm wondering, to avoid any duplication of work, is there stats available? Is there a team producing this information that we can tap into? It's Brian and Graham and I are doing it. Can we tap into that kind of information so that we can share it with providers as well? And we were looking at this in isolation. We're looking at the care at home forums. We were looking at care home forums, but with the daycare one last week, and both internally and externally, they're saying people are more complex, there's more referrals. So is there MD that could support us, or is there any teams already doing this, looking at all the information together? Because I know the direction is obviously keep people in their own homes as long as they can, but if we're looking at care at home, are the hours going up? Is it at the same time that care home placements are going down? Are daycare placements increasing? So it's just to see if there's a pattern through the whole pathway, and is there anything jumping out at the care home placements already? I know care at home's got pressures as well, but that's my comment and questions. Thank you.
Sorry?
Right. Yeah, I mean, I think that's a really sensible strategy. The more data informed the forums, the better. It avoids assumptions about why some of the patterns are occurring that occur. I mean, I can't tell you verbatim that care home placements are dropping for any specific reason, but what it would strike me as is that we're doing a better job of keeping people at home, and home first is most definitely what we're aiming for. And we have forums established that look at care home referrals, and they are very robustly looked at in terms of whether the person can actually still be at home and stay longer in their home, which is primarily what people want to do until they get to that stage where they feel unsafe. So I don't see any problem with pulling together that data. I don't think currently we have that data pulled together the way you described it though, Dave, but I don't think there's any reason why we couldn't do that. And I think the commissioning team would probably be really well placed in combination with the business improvement support function to provide you with data that would help, and probably just to kind of extrapolate some of those discussions. It's quite difficult to do the comparison with care at home at the moment because although costs have gone down, performance is not as good because, as you know, we had a large provider withdraw from the market at the tail end of last year, and there were some delays in recruitment, which, as you know, also very, very, very quickly impacts on our performance within the area. So it's a wee bit difficult to kind of tease out, you know, what's doing what in there, but absolutely we'd delighted to provide more information that's more used to the group.
Yeah, thanks, Zoe. That's great. And also where the future direction is, because we've had Ashley come along and talk about your autism, ADHD, and that could be the next wave of admissions or clients we're dealing with. But under 65s, Jane, you know, that are in hospital, there seems to be an increase in that, so that are moving to care homes. So, you know, just having that well-rounded discussion, I think that would be really good for all the providers across the whole sector and the partnership.
Yeah, I think there's something about how the care home sector looks at the moment and what it needs to look like. I think that's a really valid point. And as you know, we struggle with specialist placements in and around POA. And so I would think that those types of discussions around data would give the opportunity to have the discussion with the market to say, actually, this is where the need is for us. It's really not so much the residential placements anymore. It is the more complex placements and the under 65s, as you say, we've seen an increase in people under 65 needing a care home placement. And our care homes are full with lots of very elderly people now, and so placing somebody in a care home who's 60 with a group of 85 to 90 to 100-year-olds doesn't feel like the right thing to do. So there is just something about that market approach to care home delivery.
Thank you, Lindsay.
Thank you, Donna. I have a question on when it says lead partner arrangements at 7.22. It's an overall underspend of the amount, and you're speaking about, and you've grouped 3 areas together: prison healthcare, dental, and podiatry. Now, I'm going to put my podiatrist head on and say that I know that we do not use bank, agency, or supplementary staffing within that area. I do know, however, that within dental and prison healthcare they do. It's just a bit misleading there because there is no bank for podiatry in NHST side, okay? Also, it's the fact that it's due to supplementary staffing. Now, yes, they do get that in. However, I do know that the prison healthcare are exceedingly stretched right now. I have a meeting with them tomorrow to discuss what is happening through there just now. So I'm just conscious that yes, it's a better position that we're in from the IGB perspective, but that's a bit misleading for me because of my background in podiatry, and I know that these things aren't available to us. So I mean, it's a bit pedantic. I don't know. I'm sorry, but it's just for accuracy.
No, I really appreciate that. It's difficult when you're in the depths of this to take a different perspective. So no, I'm really grateful for that. I would say that the first sentence does describe the overall situation, and then we move on to within prisoner healthcare, and that description that comes after that is specific to prison healthcare. So, but absolutely noted, and we will take that on board for our next report. So thank you.
Thank you, Councillor Stewart.
Thanks, Chair. Thanks for the report, Donna. I wanted to ask about reserves. I see that we've got nearly £500,000 in the Primary Care Improvement Fund, and we've got £3 million in the Sustainability and Improvement Reserve, and the Council's also made available, I think, £1 million worth of transformation funding. And I just wondered when we might. I think historically the issue has maybe been one of capacity in terms of delivering transformation, and thinking of which projects specifically to spend any available monies on. So I was wondering how we're going to make sure that we, with that £3 million, for example, for sustainability and improvement, how we actually do what the Scottish Government is expecting of us, of that money to achieve, or how, for example, for the £500,000 in the Primary Care Improvement Fund, how that's, when we'll expect to see proposals coming forward for primary care improvement.
Thank you, Colin. I might answer hopefully the majority of it, but bringing either Jane or Zoe if that's helpful. In regards to the 3 million, that is around the sustainability improvement and will specifically be around rehabilitation and frailty, and there is an expectation that we're able to bring something forward that will show the benefit of us being able to use that. So absolutely, and there's a couple of dates in already. Chair might come on to it when we talk about the development sessions. The October development session transformation update will absolutely be on there, but prior to that we'd be expecting the transformation update to either be at the Audit and Performance Committee or at the IGB. So from a financial point of view, this has been something that we've not taken the eye off, because it's been part of the discussions and moving forward to making our services more sustainable with in our discussions with the NHST side and the Director of Finance. However, the detail, I do not have it yet. I've not had the proposal come forward yet for us to be able to assess and be able to recommend and assure you that the benefits being advised are realistic. But that is expected that will come forward. Now that we have our year end and our annual accounts out the way, that will be absolutely the focus of our not only the first financial position for 26-27, we're really interested in seeing how that's going to place us for the year and where we can focus our efforts, but also we need to be in and under in and around the transformation work that's coming forward. So we are looking for the proposals to come forward for the 3 million as our NHST side, as you can imagine. The Primary Care Improvement Fund, I might just ask Mark just to come into that, because that will obviously have quite a bit of commitment already.
Yeah, the Primary Care Improvement Fund was unspent funding carried forward with agreement from the Scottish Government from 25-26, and plans are fully developed to spend that funding in the coming financial year. Might bring Sal in, because I believe those discussions have been had locally with LMC reps, am I right in saying? Yes. So those funding strands are agreed, and we expect to spend that more or less in full. Thank you.
Thank you, Mark. Councillor McCall.
Thank you. Couple of questions, if I may. The first one is in paragraph 6.5, which is on page, oh, can't remember what page this one. Oh yeah, page 241 of the pack. The drawdown of funds that were set aside by Perth and Kinross Council weren't drawn down in full. So I'm just wondering where the demand has gone. Did we overestimate the demand when we went to them in October, or were we unable to meet all the needs that were there? That's the first question. The second one is in Appendix 2 on savings. Are they recurring savings or a mixture of recurring and one-off savings? And I'd also like a comment on the admissions to care homes of under 65s, but I'll come back to that by me.
Thank you, Councillor McCall. The use of the funding that was set aside by the council, and it was up to the 4.180, it wasn't used in full for a couple of reasons, and pretty much what you've outlined. As you know, social care is highly sensitive to demand and supply. However, our controls that we've put in place around the financial recovery actions delivered, and they overachieved, if you like. And the controls that we put in place around regular monitoring and reporting meant that we didn't, part of the reason that we didn't require to the extent that we had previously advised was around financial controls and recovery action success, if you want to describe it like that. The other reason is due to the older people movement around care at home, where there is unmet need now. So although the position has improved in a financial term and we don't require as much as we had anticipated, that need hasn't gone away. It's just currently not all being met. And then there's obviously the change in the way the care home placements are being used from where we predicted it to be. On the second point around savings, yes, they are all recurring.
That's music to my ears, as those on the health board will know. I'm always looking for recurring savings, so well done on that. If I may, Chair, I'm quite interested in what you said, Dave, about more people under 65 looking for placements in care homes. Is that what you said, yeah? So I know, Zoe, that there's a lot of work with the strategic leads for housing and social housing in the council. So it'd be quite interesting to know how that's factoring into the strategic housing plan. Because I'm just wondering, does everybody need to have a care home placement, or is that the only place that's available to them? Whereas in fact, if there was different types of housing, like sheltered housing or something else available. So I think the SHIP, which is the Strategic Housing Improvement Plan, I think should know. It'd be really useful to try and make sure you feed into that. You know, in terms of the evidence that we have, you know, from the providers, etc., just to say that this is what we could provide differently, because now's the time to really be doing that. It's just a comment. Thank you.
Thank you. Lindsay?
Yeah, no, I now have a comment. It's not a question. It is from my perspective as NHS staff side lead for Perth and Kinross and the staff. It's mentioned, the reason I'm saying this just now is it's mentioned throughout the report of the use of supplementary spend within NHS Tayside. I think I would be remiss to not say that the staff that we currently have within NHS Tayside, I can't speak for the council, but I think it would possibly be the same, that they are trying their very best. They are on their knees, and there is a lot of burnout throughout all services. I don't think that, I think with everything that's been asked by Scottish Government and all the asks that are asked for each organisation, and also the financial pressure that everybody's under, there is a lot of stress within the system. So it's just, I'm conscious that the transformation word is being used and reform is being used. And obviously within NHS Tayside, we do have mitigations and partnership working with a partnership promise. And I would like to think that any changes that come from a financial point of view will be then brought forward within those parameters of staff governance, so that we can make sure we get this right for both patients, and we also have to get it right for our hardworking staff that are currently on the ground. We need to keep them, because we live in an area where it feels like Brigadoon, that if you're not in the central belt, Scotland disappears and they don't come up. So it's very difficult to get specialist roles up to our area. So we need to make sure that we're looking after the staff we currently have and develop them and make sure that they are taken with us through this journey. And that's where my colleagues and staff side within the NHS and Stuart Hope within the local authority will be able to help get their views and make them be part of the journey that you will be doing through transformation. I do think we need to make sure that that is a high on the agenda when we're talking about this. And I appreciate it's a financial paper, but it fits in well with what I'm talking about. Thank you.
Thank you. That's really helpful. Maureen?
Yes, I'm looking at 6.6 in the paper there, and it says that although the mental health inpatient services sit within NHS Tayside, the IJB in Perth and Kinross still retains a strategic planning responsibility, and that's why we've been landed with a contribution of 1.18 million. How do they arrive at that figure? And given it is a service, a Tayside-wide service, why?
Thank you, Maureen. This arrangement's been in place now, or the year-end financial treatment arrangement has been in place now since I think 2020, 2021. And we do need to address that, and we need to move on from the current arrangement. However, the 1.180 that has been applied as the contribution from Perth and Kinross IGB is a four-way split of the overall overspend within the inpatient mental health and learning disability services in Tayside. So I think overall it was a £4.7 million overspend against the inpatient mental health services for 25-26, and this represents a share of that. So it's not linked to direct use of services, etc. It's probably more just a historical NRAC type share of it. We've not rebased the risk share or the budget allocation. There hasn't been the work done yet to look at that at a granular level, but this is a continuation of the arrangement that's been in place at the year end since I think 2020, 2021.
Thank you, Donna. Bunny?
Hi, thanks. My question's in relation to the care homes and the reduction in placements, and I ask it with regard to unpaid carers and their respite and right to breaks. Is there any figures that are available that would be able to show us how many of those placements have actually been to support the carer for a respite break? because the information that comes through to us is that it's usually very difficult to be able to a care home placement to ensure that carer can have their break. That's what comes back to us, is that it's not easy. So it would be interesting if it's possible to identify the figures of how much that is in relation to carers and the break, if that's okay.
Yep. So just for, I completely agree, and I think that is something that we can do. So just for clarity, this budget that we're talking about and we're referring into in the finance report is in relation to either a crisis placement or a permanent residential and nursing placement. So the reason for admission may be around carer need. However, there is a separate budget that we can report on, bring more information on around respite and a break for carers, and how much that's been used, what the budgets available are versus how much we are using, and numbers to support that if we've got them available. So we'll take an action to go and do that and try and get that included in the next report if possible.
Thank you, Donna. I'm conscious of time. We'll take one last question. Sandra?
Thank you. I wondered if consideration had been given to maybe the opportunity to utilise funding, Scottish Government funding of £20 million, which has recently been allocated via the Independent Living Fund to support the Coming Home agenda. My understanding is that the criteria for to be able to access from a person perspective is that they are red rated on the dynamic support register. The criteria I don't think is any wider than that. So this appears to be new money, and I just wonder if it would help support Perth and Kinross's patients that are waiting to move to the community.
Hi there. Yeah, ILF funding, either previously or the new monies coming, are considered in all in the consideration of all care packages of a certain level. So in the event that that was appropriate, there's already a process in place to make sure that that can be utilised to full effect.
Thank you, Jane. Can we agree the recommendations in the report? Yep. Thank you. Moving next to Councillor McColl, Audit and Performance Committee update, please.
Thank you, Chair. The IGB Audit and Performance Committee last met 2 days ago. Well, it feels a lot longer, I have to confess. One of those weeks on the 22nd of June, when we welcomed Zoe Robertson as the new Chief Officer of the Perth and Kinross Health and Social Care Partnership. As you've heard already, the most significant item of business was the presentation of the annual governance statement. Screen's just gone blank, sorry. Tell I haven't rehearsed it. The most significant item of business was the presentation of the annual governance statement together with the unaudited accounts for the committee's consideration and approval. And I just want to say that completing annual accounts takes considerable effort. So I wish to extend my thanks to Donna, Mark and the wider Health and Social Care Partnership finance and management teams for the outstanding work in producing unaudited accounts in the required timeframe and presenting them actually in such a way that they were easy to read, easy to understand, and certainly there was no ambiguity, I think, in the information provided. Certainly judging by the minimal number of questions asked of the officers, and which is not usual for a lot of the members of the Audit and Performance Committee. So I can only assume the exemplary model of paperwork. Also at the meeting, the internal auditor presented the annual progress report, as well as the progress report, as well as the annual report, giving a recommendation that reasonable reliance can be placed on the IGB's risk management and governance arrangements, and that the system of internal control, subject to management implementation of the agreed actions, detailed internal audit reports. So that was a very welcome report as well. As I mentioned in my last report, we had hoped to expand the agenda for the June Audit and Performance Committee to include forward-looking local performance targets with KPIs, but due to varying capacity issues, including my own, we were not in a position to bring this to the June committee. But I am committed to bringing this to the next Audit and Performance Committee in September. And these performance measures and KPIs will also inform the introduction of a programme of themed topics where we can do a bit more of a deep dive into particular aspects of performance within the IGB or the Health and Social Care Partnership. But overall, Perth and Kinross IGB continues to perform well, and there are no major issues to report. Copies of the papers under recording of the meeting are available on Perth and Kinross Council's website. You're all welcome to look at it, those of you who chose not to dial in and watch it live. And then the next meeting will be in the 28th of September, and papers will be available the week before. And as always, all members of the IGB are welcome to attend. Any questions?
Thank you, Councillor McCall. Any questions, members? No, are we happy to note the update, the verbal update? Thank you. Thank you, Councillor McCall. We now move over to 6.3 decision making and membership update. Can I ask Scott Henry, Democratic Services Manager, to introduce the report? Thank you.
Thank you, Chair. I'll be as brief as possible because I realise with this being the last report, I'm probably between you and hopefully getting a cool ice cream outside in this heat. The report before you updates the IGB around both the decision making and membership of the board. The main part of the report focuses on legislation that comes into force on the 1st of September to introduce additional voting rights on the board to lived experience members, namely carer representatives, service user representatives and third sector representatives on IGBs. Whilst the report is largely technical in nature and focuses on the legislation and the voting rights, I would say the same as I said to members when we discussed this at the development session in May. I've seen the work of the IGB in Perth and Kinross develop since its inception in 2015 and the positive working relationship between all members and partners. Votes at our IGB meetings have been very rare, and it's pleasing that consensus is generally reached at the board meetings, often following consultation and discussion that takes place out with meetings, and I would say that today's meeting has also been a reflection of that. That said, I absolutely acknowledge that it has been seen by some that there has been a democratic deficit on IGBs in terms of voting rights, so I therefore welcome the proposals to attempt to address this. As the report outlines, the implementation of the new legislation has been discussed at a number of levels, including the Scottish Government, COSLA and the Health and Social Care Alliance for Scotland. A Scottish Government-led working group has been formed involving representatives across the health and social care sector to review the roles and responsibilities of the IGB members. And as we know, we have Sandra as a representative on that. So any complicated questions arising from the work of the working group, I'll be passing them to Sandra. The latest guidance has been issued by the Scottish Government and is appended to the report before you. It's been indicated that further more detailed guidance from the Scottish Government should be available in August. And we've also been advised that the Standards Commission are working on producing a new advice note for all IGB members in light of the extension of the voting rights to lived experience members. The report covers practical implications for IGBs to consider, and based on the information received to date, and I'm aware that other IGBs are also considering similar reports ahead of this change coming in on the 1st of September. The IGB are also asked to determine the future membership of the board going forward. I'm happy to take any questions myself, and as I say, Sandra may want to come in and kind of comment on the work of the working group as well.
Thank you. Thank you, Scott. Any questions? Councillor Illingworth?
Do we have any information on how other IGBs are handling this situation?
I think our IGB is like others, not necessarily in the same position in terms of the membership and makeup. I think as the guidance that's appended to the report refers to, IGBs that have more than one in this category on the board are suggested that they may want to kind of look at membership. So for some IGBs, this there's not so much to sort of look at. I think in terms of other IGBs from the network that I have with other kind of councils, I'm aware that there are quite a few IGBs are taking reports ahead of the September implementation date.
Thank you, Dave.
Thank you. So I recognise this is a national directive, and I support the fact that the third sector service user and care reps are getting a vote. And I would say that I value my place on the IGB. and I do value it. But it'd be remiss of me to say that I will be the only non-voting member as an independent sector lead, and this independent sector lead will not have a vote. Everybody else have an opportunity, either themselves or through their organisation, to have a vote. So I'd just like to highlight that. That may be a national issue for Scottish Care, rather than myself as an independent sector lead. I just thought I'd highlight that fact. Thanks.
Thanks, Dave. Roisin, please.
Good afternoon, everyone. It's more a comment than a question, just to say that as part of as the lead for the third sector interface for Perth and Kinross, as part of the overall TSI network, we are currently looking at how we support members who gain these voting rights when the time comes, to make sure that people feel secure and confident in the role that they are tasked with in terms of making, being part of that decision-making process. So I felt it was just important to say that that work is ongoing in conjunction with the Scottish Government, just in the hope that it will give some security and assurance around the plans in place to make sure that everybody feels supported in taking on that role.
Thank you, Roisin. Any other questions, Martin?
I'd wonder when that advice note will come forward, because we're going to be determining something when we didn't have that advice, and if we're actually saying that they've got a voting for public sector carers and everything, that they have a vote that they're able to come on board with. So why would we trying to get more? I'm not grasping how, because the two memberships I see are 4 and 3. And if you've got one person, they surely be representing the one area that they're representing. Why we've got 2 people representing one area? That's what's not clear to me. I'm okay. But it's not clear that why we would have 2 people voting for one sector when we've got a sector that's not getting a vote.
So I think when you referred to the advice note, did you mean the advice note from the Standards Commission, or were you talking about the Scottish Government further guidance? So I think the guidance, as I said, there's been some guidance that's come out so far, and the most recent one, as I say, is the frequently asked questions one that's been referred to in the, when the legislation came out, there was a kind of a guidance note around that. So what I think IGBs are doing at the moment is reacting to that with the most information that we have as possible, and I think it's right that we consider this, because, as I say, with the change coming in on the 1st of September, as I say, the suggestion has been made that further guidance would be coming out in August, and I don't know if Sandra's get any more clarification around that. What we would then do is that I expect that will be more around about kind of the details of this, but I think, as you say, we would have to take a position as it is at the moment. Just I think in your second point around about the numbers, so I think at the moment, as you'll be aware, we have 4 voting members that are nominated by NHS Tayside, 4 voting members that are nominated by Perth and Kinross Council. We have 1 service user representative on the board, and 2 carer representatives and 1 third sector representative. So the legislation has stipulated that a vote would be, voting rights would be allocated to each of those members on the board. So as I say, that's something that we don't have any decision around. That's part of the legislation.
Thank you. Councillor McCall, please.
Thank you. First of all, thank you for bringing this paper forward in a timely manner. I think that's really helpful. I'm not sure that all IGBs have done that, but given that the legislation kicks in the 1st of September, I think it's really important that we bring it forward now so that we are able to make some sort of decisions. I personally will favour option 1. I think that we have an established balance of voting members between between the partners of the council and the health board of 4 of each, and I think it makes sense to my numbers brain that we have 4 members from the lived experience cohort. I actually don't mind how that mix is made up, to be honest. I think to some extent that might be for a wider discussion. I think option 1 gives us that, possibility to do that. But I think it brings balance, and it's an equitable number compared to the other partners that sit on this board. And so therefore I would support option 1. I just have one question though. Whatever option we decide to go with, if any at all today, if we can come to an agreement, when do the voting rights become applied from?
So it's the 1st of September. So I think our next meeting of the board is on the 10th of September. So that would be when it would be applied.
Thank you. Any other questions, Sandra?
Thank you. Just more comments, if that's okay. I guess just to highlight the status quo as it is just now, and the rationale that we're bringing that in the first place, which put Perth and Kinross really as leaders as far as other IJBs are concerned, and that's certainly with the Short Life Working Group, that's how P&K are being viewed. That decision was made at that time was aligned with the direction of travel of the Feely Review. Certainly it was aligned with the ambitions of the National Care Service, and it's aligned with the current Teesside Health Board public engagement strategy. And I think it would be really retrograde and a pity if the numbers that allow the public engagement and our sharing of workload and the representation of the public that we are able to make via our colleagues were to go backwards, as I would see it backwards. And also just to mention that the service user reference group met yesterday, and as you might expect, this is a topic of discussion. And so at that meeting, there was wholehearted support for maintaining option 1, and also not only from the members of the group that attended, but also subsequently and previously by email, there's been unanimous support. So it's just to feed into the board that there's a wider community almost that are feeding into this decision making and have a strong interest in that. Thank you.
Thank you, Sandra. Any other questions or comments? Colin, sorry.
Thanks, Chair. A couple of weeks ago now, I attended the IJB Chairs and Vice Chairs Network, and it strikes me that we're lucky that Scott has brought this paper forward, because people were looking for delays to the implementation of the recommendations so that they could go and desperately, quickly update their standing orders and their integration schemes and whatnot. So I think, again, Perth and Kinross IJB are ahead of the curve in actually having tackled this issue and brought it to the board in our report. I've heard from previously from the service user and unpaid carer representatives that when they have gone to their national meetings, Perth and Kinross IJB is streets ahead of some other areas in terms of the respect and dignity with which we invite the public partners in to contribute to our deliberations. The chair has continued the practice of having meetings with the chair, the vice chair, the chief officer, and the public partners. I understand that when public partners in other areas have heard that they have this access to the chair, vice chair, and chief officer, they're quite astounded. So I think it's definitely I want to see us adopting option 1, because I think that we're leading in this area. We're a very progressive IJB in this respect, and as Sandra indicated, anything else would be a a retrograde step.
Martin, and then
Yeah, I could support option one, but what kind of concerns me that then we're looking further down the line that we could increase that and put that balance out of kilter. I would adopt option one with 4 votes.
Scott, did you want to respond to that? Or sorry? No? Okay, thank you. Councillor McCall.
Thank you. I mean, one of the reasons I quite like option one is because the proxy arrangements will be developed in due course. And I understand that one of the reasons we do have, you know, as many public partners able to attend and contribute, which is hugely important, is that when the IGB, now somebody who's been here longer than me can tell me, but I think originally there was a member and then there was a proxy, but the proxies were not allowed to contribute. And so a decision was made, perhaps on the hoof, that whoever attends can speak. And there is a tradition of proxy membership. So certainly Councillor Stewart, I'm sorry I'm putting you on the spot, but he is a proxy member for the councillor group, and one of them in Perth and Kinross Council. But also the health board will have a proxy member. So if somebody can't, they can attend if they wish to, but if, you know, they can also substitute. So I think if we make sure that that type of arrangement is there, it still enables people to make, you know, others to make a contribution without necessarily creating an imbalance. So I think that's really important. I was quite shocked when I discovered recently that people could attend but not speak. I'm thinking, gosh, that's something I would find particularly difficult, I have to say, personally speaking. So I think that inclusion of that in option one gives us the time, I think, before the 1st of September to give some consideration as to how that would work in practice. And I personally, as a carer myself, I welcome the more contributions that there are and can be from people who have lived experience. It's hugely important. And so I think hopefully option one gives us those options to consider all of those things.
Thank you. Bernie.
I just want to make a comment following on what Councillor McCall has said, which hopefully we will find funny. But going back to initially, you're quite right. I sat on the board and Maureen was substitute and she sat in the chairs. So I would comment, but if it was something, and we all know Maureen's passion for mental health, if it was something I had missed, she would run up to me with it written on a piece of paper. It happened quite a number of times, and I think maybe that was part of, we may be better let us sit round the table.
Thank you. Do we have any other questions or comments? No, it sounds if we are looking at option one, if people are in agreement.
But it says it could, in future, to recruit another person. That's the way I'm reading it. Maybe the heat's getting to me. But it's actually saying you could recruit another person. And I'm saying no, 4 votes. You can have proxies, but 4 votes.
Yeah, Chair, just to clarify in terms of Martin's comments. So yeah, so option one, you know, for the board is to, as you say, to keep the membership as it is. So that would mean that the existing 4 members, so you know, Sandra, Bernie, Maureen, and Roisin, as I say, would retain in terms of full membership. So that would mean voting rights would be applied to those members from the 1st of September. In terms of, as I say, the proposal that we've heard so far, I think which initially came from Councillor McCall, was that, and in terms of what the board was asked there, is that there wouldn't be any further recruitment done for a service user representative, but obviously we'll continue with the recruitment regards the 2 carer representatives, which was due to come in anyway, and would of course be open for Maureen and Bernie to apply to. So that's my understanding of where the board's decision is at present.
Thank you. Councillor.
So I think what's really important here is about the position of the proxy arrangements, because we don't have proxy arrangements because everyone can speak. So I think in conjunction with all of that, that's the crucial part for me in this recommendation, because it's quite pertinent. We can still, you know, it's up to the different organisations if they want to, you know, say we would like to recruit somebody else, but they'd be a proxy member, but they'd still be able to speak and contribute. and they would be able to substitute if needs be for voting rights. That's my understanding of it. So hopefully that's everybody else's too.
Thank you. Colin, did you want to come back in? Sorry, I'll go to Sandra first and I'll come to you.
Thank you. I guess I would just like to put to the board the benefits that I have previously found with my service user colleagues, and the support that they give, and how, just as I mentioned earlier, how that widens a perspective. The workload is, and bearing in mind that these roles are unpaid, and our contribution to some of the other groups feeding into the IJB, like the strategic planning group and like the audit and performance committee, that is quite a lot for a single individual. I would still work full time in addition to my contribution to the IJB. So I would like the opportunity for you to consider recruiting the service user position, please.
Thank you. Councillor Illingworth.
I'm not 100% clear in my mind. Does option 1 mean that there will be 4 extra voters and that will stay at 4 even with extra recruitment?
The short answer is yes. I think if the recruitment, there's 2 types of recruitment I think referred to in there. So there's the recruitment that we were doing anyway, which is almost independent of the voting rights issue, which is because Bernie and Maureen's positions are due for reappointment anyway. So that will happen. So that's the recruitment there. As I say, if the board continues with the status quo, then from 1st of September, the 4 existing members would gain voting rights. I guess the other decision for the board to make, which has been alluded to, is as you say, the potential replacement or recruitment of an additional service user representative to replace what was Nettie's post.
Thank you. Martin, did you have another question?
Just an observation, if we're going down that road, will there be an accelerated training programme? Because it's going to shift the dynamic, and it's going to shift the roles and responsibilities and the understanding, and we've got the 1st of September.
I think the report makes reference to and again, I think that this has also been discussed through the short-lived working group in terms of, there would be an expectation that there will need to be additional kind of training, and I think that the point's made that whilst these positions are not remunerated in terms of early salary, I think that given the additional responsibility that comes with the voting rights, I think there would need to be support for additional training. And I think, as you say, the Health and Social Care Alliance has kind of referred to that in terms of recent communications. I don't know if Sandra, you want to come in.
There are a couple of aspects of support that are being discussed by the short-lived working group, and it looks likely that there might be national sort of standardised options which IJBs could choose or not to avail themselves of around training. And for example, the Standards Commission there may be training that they're putting in place, but certainly the Health and Social Care Alliance, I understand, are.
Thank you. Thank you, Sandra. Roisin, please.
Hello, I'm really sorry. I think this is more of a clarification, I think, just around the whole proxy situation, because I think it's a really valid point that's been made about the commitment that we give when we come along as members. And if we're going to have voting rights within the context of all of the other things everybody does, it's the question over the proxy system that I wanted to clarify, because I know, like certainly in Dundee, their IJB voting members have proxies. and it would be really helpful for us to have proxies, because there may be occasions where there's a diary clash and we couldn't, I mean, obviously, like, every effort would be made to attend personally, but there may be times, you know, where somebody would need to have somebody to step in for them rather than miss a meeting. So I'm just looking to clarify that that is the plan.
Yeah, just to come in on that, I think we mentioned in the report around about we'll need to look further at proxy arrangements. I think we've always had a sort of informal arrangement on our IGB around about proxy members. I think, as you say, because of the nature of you're bringing in with the voting right, I think we would need to be maybe have that as a bit more structured. So absolutely, taking your point in terms of your representation and the support that would be there from a proxy and helping to attend meetings. I think we would come back, and I would hope that perhaps there may be some further guidance in that additional information that's continuing to come out from the Scottish Government around this. So yeah, I think we would need to take a maybe a future board meeting just to firm up around about proxy arrangement.
Okay, that's great. Thanks. That's really reassuring. Thank you.
Thank you, Roisin. Heather?
Thanks very much, Scott. And like Councillor Illingworth, I'm still confused, so apologies for that. I really value the lived experience members and the contribution they make, and I think we would all agree with that. I'm just, I'm supportive of option 1, 4 members. I still didn't understand what you said with regards to the board would need to decide whether to recruit the remaining vacant service user representative. Would that be a service user representative who would come but not have a vote? Because we're talking here about approving something that says the current structure and increasing voting membership by 4 additional members. It doesn't say by 5, it says by 4. So I think we need to be clear on that. That's where I'm a bit confused at the moment. I would certainly support 4.
Yeah, apologies if the wording of that wasn't completely clear. So yes, so if, as I say, the board at the moment we have 4 lived experience members in that category. We have 1 service user representative, 2 carer representatives, and 1 third sector rep. We had Nettie not resigned, we would have had the 2 service user representatives. So the board needs to decide whether, if it does want to recruit to that further service user representative, that would increase the number to 5 voting members in that lived experience category. So yes, to answer your question, yes, if we did recruit a further service user representative, they would have votes in line with the legislation that's coming in.
Any further questions on this? Martin?
I could support 4, I can't support 5.
Thank you. So option 1 or option 2? Option 1 as it currently stands is for the 4 members. Sorry, Colin, did you want to come back in?
So just on this question of whether we open the, what do we call it, a selection process, election process, recruitment process for this, for the vacant service user representative. We've heard the ask from Sandra that we do that. We've heard how much we valued Nettie's contribution when she was here, but before Nettie it was Serene McCartney, and while Sandra was on the National Care Service Advisory Board, Serene was co-chairing the strategic planning group. I think this would create an unwelcome disparity between the service user and carer public partners, and I think we should agree to retain the existing membership as per option 1, but also proceed to recruitment for this service user representative.
Thank you. So moving forward, I'm conscious of time, but recognise that it's an important issue. So option 1 currently is 4 members plus 4 proxy members. Oh, well, 4 voting rights as it currently stands, without the recruitment. Do people wish to move forward on that basis?
I'm conscious I don't actually have a vote on this, okay, but I would actually like to see that it would be for NHS, for local authority, and for, I'm not saying I don't value anybody, but it just means that everyone's got the same amount. In my head, that means that it's fair, and everybody has the same amount of votes around the table. So that's where I'm sitting at right now. If I had a vote, which I know I don't, so it's fine. But I just think it would be better to have everybody having 4.
Thank you. Sandra, did you want to?
Just again, just to make a plea and just to remind the board that the service users, so myself and Nettie, were elected by a democratic process in which there were a couple of hundred people voted for our election onto this board. So yeah, so just to make those around the table that maybe didn't know that this was a formal democratic election process. Thank you.
Thank you, Sandra. So I'm conscious of moving forward and option 1.
So I think the second bullet point in option 1, I think, is what's causing some of the confusion, because it's ambiguous as to whether or not, if we do recruit to that, whether it be as a proxy member or whether or not be as a voting member. I think my position is quite clear, and it's again to do with balance of the partners that sit on this board with voting rights, and that it should be 4, 4 and 4. I think that's fair. And I think I said when I first spoke that I'm quite ambivalent about whether or not how that cohort is made up. But I do think we do need to have the proxy membership, in which case you might have more people, but they still can speak and contribute, but there'd still only be a maximum of 4 votes. So I think that second bullet point is ambiguous, and is what's causing some of the confusion. Is that correct? So I think maybe we need to think about either we withdraw that question, but we need to look at proxy arrangements to be developed in due course, including recruitment to those posts, because I just think we can't have that ambiguity. And also, how is the decision made whether to recruit to the remaining vacancy? Is it done by this board, or who decides that? Because that's not clear to me at the moment. But I think the overriding sense I'm getting from around the room is that we should increase the voting membership on this board by 4 to be 4 voting members from the public partners. And I think that's really what we're been asked to consider. There's some mechanics behind that, and we have some time between now and the 1st of September to understand how we implement that, who will have the voting rights and who won't, and that's for the public partners to some extent to decide. But I think we need to maybe be clear about what we're voting on.
Thank you. Colin, did you want to come back?
Thanks. Just to point out that had Nettie not resigned, you would be currently faced with a situation where you would have to be deciding which of the public partners you would you would remove from the board.
Sorry, Colin, that is not what I'm saying at all. Yeah. What I'm saying is that we will increase the voting membership of this board by 4 to be drawn from the public partners. And my very first comment was that it's really up to the public partners to decide how that would be done. I think the reference of proxy arrangements is crucially important, and I think we need to understand how that gets done. But I think the decision before us today is whether or not we increase the voting membership effective from the 1st of September to 4 voting members from the public partners. And I think that's, if we need to amend this option 1 to make that clear, I think that's probably what we might need to do. But this is not, and I would still be having the same argument irrespective of the number of people who come and contribute to this board. Because I think that's the balanced way to go forward, so that all of the contributory partners, NHS, the public sector partners and the council all have an equal number of voting rights.
Thank you. Sorry, Martin.
I'm supportive for Councillor McCall's analysis. That's the analysis that I've got. We're voting for 4 members. And that's it, 4 members. So it's actually an increase of 1 member for what was actually recommended. There was only 1 each. We're going a wee bit over and above already.
Just to clarify, and I think I would recommend that perhaps, as I say, in terms of trying to move this discussion forward, we probably do, in terms of standing orders, need to move to the kind of more formal motion and amendment setting. I think in terms of the options, in terms of Councillor McCall's point, it would be competent for the board if they wish to, as I say, move to having the status quo of the 4 members on the board, and if they wanted to to formally accept or propose that we had proxy members available for those members, that would be within the board. What we couldn't do within the confines of the legislation is to say that we keep the status quo, but the lived experience members decide between them, because as of 1st of September, the 4 lived experience members would all carry a vote. So it was just to clarify any confusion around that. But as I say, I suggest, Chair, that we seek a motion to formally move, which I think it sounds like Councillor McCall's already doing.
You're happy to? All those in favour of Councillor McCall? Oh, sorry. Apologies, I'm still getting used to this. Any amendments?
I will put in an amendment, but I just want to clarify with Councillor McCall, as the mover of the motion, that you are proposing not proceeding with the recruitment of a further service user representative.
What I'm proposing is that we extend or approve 4 additional voting members, and that we examine the proxy arrangements within the recruitment process for the members that are there. I don't know how to word that properly, but so yeah, I mean, I think there's some wording around that, but really, I mean, I'm not objecting to a vacancy being filled, but if it has to be filled, then it needs to be a proxy, for example. But I don't know enough about the legislation around proxy members, but I definitely would but for this meeting here today, we're voting to expand the voting rights by 4 to the public partners, and whether it's the existing cohort or not, I think we should say this is what we're intending to do. Yeah.
Right. So in terms of the second bullet point, so in the recommendations at the start of the paper, we are 2.5 to consider the options set out in section 7 of the report and determine the future membership of the board from the 1st of September. The second bullet point says that the board would need to decide whether to recruit to the remaining vacant service user representative. So can I ask whether the motion is deciding to recruit or to not recruit?
Sorry, to not recruit. I don't think we need to make that decision today.
Right, then in that case, my amendment is that we adopt option 1, and that we do, for all of the reasons previously given, I won't repeat them in making this amendment, but that we do recruit to the remaining vacant service user representative.
Sorry, is there a seconder for Councillor Stewart? From the voting members? No. Okay. So the amendment falls and the motion's agreed. Thank you. Any more comments?
Although this whole discussion and the paper has focused on the voting right aspect of the legislative change, remembering that the paper that was submitted to the IGB chairs and vice chairs group in November 2022 was about parity of representation, and that's actually been the core of this. Remembering that the last vote was 2019, this is about public partners having equality and parity, not the voting piece is an output of that, but it's about changing the attitudes and values and all of these important things. Thank you.
Thank you, Sandra. Thank you, everybody. Yep.
Thanks, Chair. So just to clarify, we had the motion from Councillor McCall, which was seconded by Councillor Frampton. So it's been agreed by the board that the 4 public partner voting members will increase the membership, and we'll come back with future proposals about proxy agreements. Has everyone agreed to that? Yeah. Yeah, of course.
Can I formally record my dissent to that, please?
Thank you.
Can I just say, Chair, you know, first of all, I'm delighted that you have voting membership. I think the contribution is hugely important. And we often have conversations offline as well, and we have lots of things in common in terms of our approach to things. So I think it's very important. So thank you. I don't underestimate the change that might happen as a consequence of that for you also. I think that's equally important. But what I was going to say, Chair, is that it may well be that, you know, you might want to have an extraordinary meeting at some point before the next full board meeting to include just the voting members, to perhaps consider some of the questions that were raised today about recruitment, about proxies, so we can try and get to some sort of understanding of what that means in practice, rather than leave it to the next full board meeting when there's probably going to be a full agenda.
Thank you. Maureen.
Just a comment. How often do we actually have to vote? You know, that is the thing. You know, it's a lot of discussion, you know, about something that rarely happens actually, you know. So.
Thank you. And I agree with Sheila. It's welcome. So it's great to have you on board. I'm just conscious of time, so moving on. Next, we have the Integration Joint Board Work Plan and Development Sessions for information. For the October session of the development session, we're proposing to bring the subjects of transformation, public dental service, and the United Nations Convention on the Rights of the Child as 3 key subjects. And then we have the future meeting dates and development sessions listed.
Just noting that the September meeting is a Thursday, that neither Bernie and I can attend on a Thursday. Both of us have standing other commitments. I'm sure there's a good reason why it's a Thursday rather than a Wednesday, but it's just to.
Checking the council calendar, the Wednesday of that date is a planning and placemaking committee. That is one where there can be, you can't give a fixed time for how long it might overrun by. And I think we have actually been displaced previously by the Planning and Placemaking Committee. So I think that's why it's gone in on a Thursday. But I was chatting to the clerk, and we will see if the Friday would be available instead, if that would suit. Okay, just for info.
We'll take this offline if we can. Thank you, everybody. Enjoy the sun. Thank you.